वीडियो का।
हाँ
गुड इवनिंग सर। डॉक्टर सरीन गुड इवनिंग।
क्या हाल है, कैसे हैं अजय जी? गुड इवनिंग, वेरी गुड इवनिंग, क्या हाल है?
गुड इवनिंग डॉक्टर वासुदेव।
Hi, good
गुड
evening.
इवनिंग सर, वासुदेव सर, गुड इवनिंग। हाउ आर यू सर?
All good. मैं दूसरे लैपटॉप पे मेरी दूसरी मीटिंग चल रही है, तो अभी उसको मैंने साइलेंट किया है। मैंने कहा I'll join this now.
हाँ जी सर, हाँ जी, हाँ जी।
और वो 4 बजे से चल रही थी और अभी 6 o'clock टॉक्स थे, तो
बहुत हेक्टिक हो जाता है सर, बहुत हेक्टिक हो जाता है नहीं
हो गया। तो ये
समटाइम्स।
दिन ना, फ्राइडे सैटरडे संडे इतनी मीटिंग्स और इतनी वो सोशल फंक्शंस भी और शादियां भी 2 अटेंड की मैंने। रात को 2
यस
बजे
सर।
मैं शादी से तो काफी हेक्टिक है। वीकेंड बड़ा बहुत टाइट है। आई डोंट नो, so many
और सर बताएं कैसा चल रहा है सर? सब बढ़िया
बस
चल
आप
रहा है?
बताएं। राजस्थान इज गुड।
हाँ सर, सही चल रहा है।
डेंगू कम हुआ थोड़ा कुछ?
हैं जी?
डेंगू कम हुआ? डेंगू
डेंगू
फीवर
कम हुआ सर, सर्दी आने से डेंगू कम हो गया,
कम हुआ?
काफी कम हो गया सर डेंगू।
हमारे तो वी वर गेटिंग सो सिक पेशेंट्स आईसीयू में, पीक्यू में, इतने सारे बच्चे। ऑलमोस्ट देख रहा था कि 50% बच्चों को रीनल फेलियर हो रहा था एंड दे नीडेड डायलिसिस, सीआरआरटी, एंड मोर्टेलिटी वाज सो हाई। 25% मोर्टेलिटी थी हमारे इसमें, विच वेरी हाई
और सर
मोर्टेलिटी।
डिफरेंशिएट करना बहुत मुश्किल हो जाता था सिंपल वायरल से। हाँ सर।
नहीं, हमारे पास तो जब तक डॉक्टर सरीन पहुंचते थे ना, देवर इन सच अ बैड कंडीशन, शॉक एंड वो जो लैक्टिक एसिड वो था इंक्रीज, हाइपरलैक्टिमीमिया, वो कंट्रोल ही नहीं हो पाता था।
हाँ जी सर।
डायलिसिस से, सीआरआरटी से लैक्टेट लेवल्स ही कम नहीं आ रहे थे। आई थिंक बियॉन्ड अ सर्टेन लेवल व्हेन दे गो, सेल डेथ शुरू हो जाती है, फिर उसको रिवर्ट करना बड़ा मुश्किल होता है। लेट आते हैं ना, थोड़ा सा भी लेट हो जाते हैं। फर्स्ट 2-3 दिन पेरेंट्स थोड़ा सा वो कि वायरल होगा, अभी देखते हैं करने में।
सर सबसे ज्यादा था प्लेटलेट से लोग, पीपल और बॉदर नॉट अबाउट द कंडीशन, प्लेटलेट्स कि कम क्यों हो रहे हैं, इसके कम क्यों हो रहे हैं सर, यही दिस वाज बेसिकली, इसको लेके इतना ज्यादा वो पजल थे।
सर क्या होता है कि दे आफ्टर द प्लेटलेट नॉर्मली 5th और 6th डे पे कम होते हैं, तब तक वो कैपिलरी लीकेज, दे डोंट रियलाइज द कैपिलरी लीकेज इज हैपनिंग। बिल्कुल शॉक में चले जाते हैं, बट तभी आते हैं वो।
पर सर एक्चुअली क्या है कि जो पेशेंट आता है ना, वो कहते हैं साहब इसलिए लाए, इसके प्लेटलेट कम हो रहे हैं, हम इसलिए भर्ती करा रहे हैं। उनको तो ये प्लेटलेट्स, और अपन उनको समझा भी देते हैं कि 7 डेज के बाद बढ़ेंगे, धीरे धीरे कम भी हो जाए, कोई जरूरत नहीं है ट्रांसफ्यूजन। तो कहते साहब आप तो इलाज करो, प्लेटलेट्स तो कम हो रहे हैं सर, इलाज के बाद और कम हो गए हैं सर। ये बहुत लोगों में बहुत फोबिया था सर, बहुत फोबिया, बड़ी मुश्किल से उनको समझाना पड़ता था, बहुत दिक्कत।
हेलो,
गुड इवनिंग मैम।
हाँ गुड इवनिंग मैम।
Good evening, Dr. Sarin. Good evening, Dr. Vasudev. Good evening, Dr. Ajay. I think Manish is also there.
हाँ डॉक्टर अजय हैं, डॉक्टर मनीष भी हैं मैडम।
मनीष कहाँ है? मनीष नहीं दिख रहा।
मनीष कहीं अटेंडीज में तो नहीं?
नहीं हो सकता था। Maybe
ये
because
लिखा तो हुआ है डॉक्टर मनीष गुप्ता यार, बट वो डीआईपी के प्लान आ
हाँ,
गए।
हाँ।
there he
वो
is.
है ना खुशी, खुशी हैज जॉइन, आई थिंक खुशी।
हाँ हाँ।
डॉक्टर मनीष भी आ
गुड
गए।
इवनिंग डॉक्टर मनीष।
Hello, good evening,
Yes, sir, I'm
everyone.
here.
हाँ खुशी इज देयर। सो एक्चुअली क्या है, डॉक्टर उपेंद्र नारायण रेड्डी को ना कहीं जाना था कोई फैमिली फंक्शन में। तो
Good evening,
मैसेज किया
everyone.
था कि अभी नहीं ज्वाइन कर पाएंगे, हो सकता है लेट ज्वाइन करें वो। मैंने कहा ओके।
I just came for the Swar Sangam. The full flow practice rehearsals are going on today. Today, madam, it was in actual studio with the Remy studio of Mr. Popley, And they were full orchestra. The whole songs were being practiced with full orchestra today. It is coming up very well, and we all must attend right from the start. It would be a wonderful program.
It is physical, virtual.
Yes, sir. It is physical, ma'am. 6 o'clock.
6 auditorium. आपके auditorium.
Madam, you are chief guest in that.
The thing is,
मैम ने मैमसी छोड़ दिया ना, तो मैम मैमसी को बाय बाय कर रही हैं.
नहीं.
Dr. Piyush and Dr. Sangeeta are the chief guest, ma'am.
हाँ नहीं. Actually, I was trying to keep track of things. I was just recalling things.
Welcome, Dr. Lalit.
28th Sunday. Dr. Lalit तो अभी भी स्वर संगम की ड्रेस में ही है, मैं भी.
कहाँ पे है स्टूडियो? कहाँ पे था मनीष?
Yes, sir.
How nice to see you.
Sir, ये हरिनगर में है. Mr. Popli का स्टूडियो है. Hello, Dr. Mahesh sir. Welcome.
Good evening, Dr. Parmesh.
Dr. Parmesh sir आ गए हैं.
Joining.
Welcome, Dr. Parmesh sir. वो एक्चुअली क्या है, कहीं उनका नेट बहुत पुअर, वो करते मेरा नेट आएगा नहीं आएगा, अगर नेट आ गया तो मैं आई विल ज्वाइन, तो रिक्वेस्ट की थी उनसे सर आज आ जाए. परमेश सर, गुड इवनिंग.
He's trying to connect. He's trying to connect.
Trying to connect.
मैडम 1 मिनट बाद है मैडम, आप परमिट करें, टाइमली अपन शुरू कर देंगे. टाइमली हमेशा अपन 7:30 पे करते हैं.
आजकल नेट का इतना प्रॉब्लम है ना कि at least 4 to 5 devices are running simultaneously on high widths, bandwidths. सबका work
in
from
between
home.
the net is really causing problems. Sometimes it becomes so slow. I don't know what is happening. ये 5G आ रहा है ना, इसलिए 4G को थोड़ा outback कर रहे हैं ये. They do it actually.
मनीष इतना ज्यादा लोड है कि अभी वो हार्डवेयर हैंडल ही नहीं कर पा रहा है. इनका बहुत लोड है. इवन विद फाइबर ऑप्टिक जियो, मेरे जियो का भी लगा हुआ है, एंड एयरटेल का भी है.
It is 7:30. Shall we start?
Yes sir. Yes sir. मैडम स्टार्ट करते हैं. संगीता मैडम.
Yes, sure.
और परमेश सर मेरे को आई थिंक जब वो नेट आ जाएगा वो ज्वाइन कर लेंगे.
Right, sir.
Dr. Parmesh is there.
So welcome all friends, delegates, our senior dignitaries and CIAP officials. Respected Dr. Sangeeta Yadav Madam, Vice President, CIAP Northern, and welcome Dr. Paramesh sir. We are so happy to have you, sir, guiding us in day 2 of CADE module. Dr. Vasudev sir, Dr. Devendra Sareen sir, Dr. Lalit Mehndi Ratta, Dr. Ajay Gupta, and all my dear delegates who have joined for day 2 of CADE module. Yesterday was a very successful and interactive day. We had 3 very good sessions, and today again 3 sessions are lined up. And I request our senior members, especially Dr. Sangeeta Yadav Madam, to open today's proceedings, and then we can start the proceedings.
Thank you, Dr. Manish. Very good evening and welcome all to the second day of the CADE module. And I welcome Dr. Parmesh, who is a very senior IAP member, and I have a lot of respect and regard for him and for his passion towards the pulmonology and the various issues. And he has been a guiding force, not only in national, but even in the international arena. And I have attended a few meetings and workshops also with him. Welcome, Dr. Vasudev, always enthusiastic and leading all of us from IAP Delhi. Dr. Devendra Sareen, the North Zone, the coordinator, and ever enthusiastic person, always there for these academic programs. And in absentia, I welcome Dr. Upen Narayan also, and Dr. Lalit Mehndi Ratta, President IAP Delhi, Ajay Gupta as EB member, and all of them are so dynamic and that they are ever enthusiastic about running the various programs. So yesterday we had a wonderful topics we had, very practical, and everybody can relate to these topics like allergic rhinitis, anaphylaxis, food allergies, which are such common things. And today we are going to have 3 sessions on allergy skin testing, air pollution and allergies, which is a big thing these days, especially because we are all talking about and going through this air pollution, and of course chronic urticaria. And today it is going to be Dr. Nagaraju's lecture which will be there, and on allergy skin testing, and we miss him. And like I said yesterday, that was the workshop which he had conducted in 2017 in the Bangalore Pedicon, which me and my husband, we both had attended. Even Dr. Lakhan had attended. We were all, we actually participated in that workshop and learned so much. So my salute to him for his dedication towards this mission which we are taking forward. And so with these words, I feel that we will have another very interesting sessions today. All the best for this program. And once again, I'm sure all our participants and delegates are going to enjoy the presentations as well as the interaction related to the sharing and learning of the experiences. And Dr. Parmesh is there to bless all of us for this program. Thank you very much.
Thank you, ma'am. Now I request Dr. Parmesh sir to address the delegates, please, with his vision and his expertise. Dr. Parmesh sir, please, your comments, sir. Sir, please unmute yourself.
Sir, unmute kare, Parmesh sir.
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
I am in what is this place? I'm in Mahabaleshwar. I have a problem with this one. You have to bear with me. First of all, sir, again, thank you very much, and Delhi IAP and office bearers and yourself for inviting me to speak few words of the inauguration of this program. And it always makes me to remember the Professor Nagaraju. And it is effort and IAP office bearers. The total efforts is in a week he is able to create this problem, and the
There is some issue with the connectivity, Mahabir.
And I have a great pleasure. Yes, well, Narayan Reddy is there. Narayan Reddy and
yesterday sir was there actually.
Okay, both of them.
He will join later on.
Yes. So both of them are taking this module that the grassroots level and update the people importance of the air pollution and the health and global warming, climate change. They're all related to. Recently, we concluded the COP29, where all these issues were discussed, and we have to work on that one, mitigate the problem at the international level, national level, and local level, what you can do. These are all the issues we are going to hear from you people. And I have a great pleasure inaugurating this conference. Thank you very much for again inviting me. It's an honor for me. I remember my Nagaraju. I'll never forget him. As a matter of fact, we jointly work together. Thanks a lot for giving us this opportunity for us to say a few words.
Thank you, sir. Last
Please,
2 decades from you and Dr. Nagaraju, sir, we have learned so many things in allergies, sir. Really best to have you, sir, here.
Thank you. Thank you.
Thank you, sir. And now with experts as Dr. Vasudev, sir, and Dr. Sangeeta Yadav, madam, will start today's academic sessions. And there is a slight change. Allergy testing, a recorded video of Dr. Nagaraju, sir, will have at the second slot. And the first slot would be taken by Dr. Devendra Sareen, a very senior pediatrician from Rajasthan, whom everyone knows, coordinating so many CIAP activities and a very active senior central IAP official. Dr. Devendra Sareen, sir, I request, sir, and welcome, sir, to speak on allergy and air pollution. Dr. Devendra Sareen, sir.
Yes.
Thank you, Dr. Manish. Thank you so much. Khushi, we can start sharing the slides. Sir, am I audible and slides are visible?
Yes, sir, both.
Okay, sir. Thank you. Thank you. Honorable Dr. Parmesh, sir, Madam Sangeeta Yadav, Dr. Vasudev, sir, Dr. Ajay Gupta, Dr. Manish Gupta, Dr. Mehndi Ratta, and all my dear colleagues and all the participants and DIAP, with the blessings of Dr. Piyush Gupta, sir, Dr. Basavaraja, sir, Dr. Ramesh Kumar, sir, and Dr. Bakul Parikh, sir, and the blessings of Dr. Parmesh, sir, and Dr. Sukumaran, sir. We are taking this module under the guidance of my brother, Dr. Upinarayan Reddy, and my friend, Dr. Jose. We are trying to taking this forward to each and every part of the country, as was the desire of Professor Nagaraju, sir. I dedicate this lecture with respect to Dr. Nagaraju, sir. So we start with the allergy and air pollution. Now the question is why we are discussing allergy and air pollution. We know that the patient comes to the pediatrician, the patient has some respiratory problems like allergic bronchitis, allergic rhinitis, and the child is not being cured. So sometimes we change the medicines, we change the every other things, and we try to cure the child. And sometimes we know that the child is not being cured, so we have to search for any other cause. That is why there is nowadays the need of the allergy and air pollution is becoming more important. We all know that air pollution, global warming, and climate changes are interrelated, having a great impact on allergic diseases. Now, as a matter of fact, the airway allergies are the earliest onset, non-communicable environmental diseases with significant socio-economic health burden. The airway allergies like asthma, allergic rhinitis, and comorbidities with sleep disorder, breathing, and chronic cough are a global epidemic, where women and children, which is a vulnerable group of the society, they suffer more. And it is very interesting to note that 70% of the diseases caused by environmental pollution are non-communicable diseases. And 70% of the non-communicable diseases are from air pollution. Now, outdoor as well as indoor air pollution, both of them are responsible for significant death all over the world every year. Now, fossil fuel alone, mind it, fossil fuel alone can cause premature deaths of 79.16 lakhs in Asia and 26.6 lakhs in India, which is a quite significant figure. Now, welfare losses from pollution are to a significant extent all over the world. Hence, the adaptation to the climate change is very essential in primary prevention of allergy airway diseases. Now, if we see the history, about 3 decades back, the communicable diseases were predominantly seen, headed by pneumonia, tuberculosis, pertussis, and measles. But with the use of the proper antibiotics and with the advent of the vaccination, they have been reduced significantly from 61 to 33%, as shown by the red arrow. But on the other hand, if we see the blue arrow, it indicates that the non-communicable diseases for the last 30 years, headed by bronchial asthma, allergic rhinitis, has increased significantly, about doubled 30 to 55% in the last 30 years. So hence, these diseases, we have to pay attention for them. Now, the allergic diseases, allergic asthma, and allergic rhinitis. If we see the allergic rhinitis in general population, as shown by the left-sided, this bar diagram, we can see in general population, 1994 was only 22.5%. But in 2004, it has increased significantly up to the extent of 40%. When we see the asthmatics, in them, the allergic rhinitis was 75%. And in 2011, it is almost 100%, 99.6%. And Professor Nagaraju always used to say that nowadays, every asthmatic child is having some degree of allergic rhinitis. So when we see about the allergic bronchitis, we can see from this graph, the red one shows that there has been constant increase in the prevalence of the bronchial asthma, about 28% now. And simultaneously also, the persistent asthma has also increased from 4 to 72.5%. And also the persistent severe asthma has also increased up to 11%. So persistent asthma and the persistent severe asthma both require a prolonged treatment. Hence, we are mentioning about them. So what is responsible for the increase in all type of asthma? It is because of the change in the demography of the city and mainly because of the air pollution. Hence, it is very important to discuss about air pollution. So before we go into the details, there are some interesting case scenario. A 16-year-old school-going teen is having moderate to severe persistent allergic rhinitis. She is on intranasal corticosteroid for the last 3 months. The compliance and the technique is very well ensured. But the symptoms worsened for the last few weeks and she needed regular antihistaminics. Because of that, because of the symptoms, her sleep was disturbed and she was not able to concentrate in the studies. When we performed the skin prick test, it showed house dust mite allergy was positive test 8 into 8 mm. So further we inquired and we got the point that the elder brother is on a regular inhalers for asthma. Means the genetic history is positive, family history is positive. Now, the next point, the grandfather of the girl recently shifted with her and the grandfather is in habit of smoking the bidi daily. So environmental tobacco smoke is also there. Now, when we inquired in details about the housing condition, the sunlight exposure in the home was negligible. So we know that wherever there is less of the sunlight or there is improper ventilation, these children are more prone, 3 times more prone to develop the allergic diseases. Now, further we inquired that in the October and November months, there were exacerbations in the past. Now, why October and November months? Because in that time, the more of the crops, the farmers, they burn their crops and the remnants of the crops, they are causing the environmental tobacco smoke. So that is one of the factor. And the pollen allergy is also common in these months. Now, further, she is residing in the urban area of Delhi and Delhi is our capital. And we all know that Delhi is very much overcrowded and it is one of the most polluted city of the India, of the world we can say. Then the construction activities are present in the nearby areas. There was construction going on near the child where that she was residing. So the construction activities are also the 4th important cause of the air pollution. So all these factors were acting in this poor girl. Whom to blame? Should we blame the genetic factors? Should we blame the environmental tobacco smoke? Should we blame the city, overcrowded city of Delhi? Should we blame the construction activities going on nearby or the house dust mite allergy? So all these factors were acting in this child and leaving the genetic factors, we could control all the indoor air pollution and the outdoor air pollution. So hence it is very important to know what is the etiology so that we can help this poor child. Now, from where the air pollution is being coming, from where the air is polluted. Now, it can be from the natural sources or the non-natural sources. The natural sources are the bursting of the volcanoes and the other sources are the burning of the stationary, forest fires, and also the decay of the dead animals and their gases. And nowadays, very important is the automobile. Most important, from the automobile, there is going to be more of the air pollution. So in the air pollution, they are either the primary pollutants or the secondary pollutants. What are the primary pollutants? They are what sources we discuss. They will all form the primary pollutants. It is containing the most suspended particles, hydrocarbons, and some of the gases. Now, it is a double-edged sword, the primary pollutants. They are causing the air pollution, and also with time, they are being converted into secondary pollutants. So when they combine with the water of the atmosphere, the sulfur dioxide can form the sulfuric acid, and nitrogen dioxide can form the nitric acid. So the secondary pollutants will be formed. So all these primary and the secondary pollutants are responsible for the air pollution. Now further, when we see the air pollution can be either outdoor air pollution or the indoor. So when we see the outdoor air pollution, we know automobile exhaust is a very important factor. It is directly affecting the airways like nitric oxide, sulfur dioxide, ozone, suspended particulate matter, photochemical oxidants, then certain toxic substances like carbon monoxide, lead, and certain carcinogenic like benzene, polyaromatic hydrocarbons, and aldehydes. Now, there are certain other outdoor air pollution, power plant emission, very important, open burning of the solid waste, construction related activities, dust, then mining activities, pollens and fungus. So these are all outdoor air pollution. Now, when we talk of the indoor air pollutions, it can be either aerobiological or the irritants. In the aerobiological, the dust mite is one of the most important cause, 60%. And Professor Nagaraju always used to say, if you control the dust mite, you have controlled most of the indoor air pollution. Now it is followed by cockroach, pollens, fungus, pests, and virus and bacterial infection. We see that viral and bacterial infection, once they affect, especially the infants, then subsequently these children, when they grow up, they suffer more from the allergic airway diseases. They are the wheezing children subsequently. When we talk of the irritants, tobacco smoke is one, mosquito coil, agarbatti used in the homes, cooking fuel, very important nowadays, cooking fuel, then formaldehyde and volatile organic compounds. Now, the indoor air pollution, we can say with the knowledge, with the awareness, the indoor air pollution has decreased up to the extent of 65%. But the outdoor air pollution has increased significantly for the last 2-3 decades. It has increased up to the extent of 115%. So we have to control both the outdoor as well as indoor air pollution. Now, the quality of the air which we inhale. Everyone wants to inhale the best quality, and it is containing the nitrogen about 80%, oxygen about 20%, with some of the other gases and water vapor and some other inert materials. So air is a mixture of many gases, moisture, and some inert materials. The nature has self-purification process. Imbalance in the process causes ill health. And very important is that the air pollution has impact from womb to tomb, that we'll discuss later on. When we talk of the air quality index, very important, as defined by the WHO, and it has been recently with the what the IAP has given beautiful, very good, last week only, the about the for the parents, they have given the guidelines, environmental air pollution, and they have mentioned, and that Professor Parmesh sir was also one of the guiding force in that. And then it has been mentioned that if it is 0 to 50, it is good, 51 to 100, it is satisfactory, and it is 100 to 200 moderate, 200 to 300 poor, and 300 to 400 very poor, and 400 above is a severe air pollution. So if we control, if the air quality index is below 100, it means it is good. The air pollution is minimal. But if it is more, say more than 400, it means it is severe air pollution. So it is definitely, when we see the air quality index, we get an idea how much is the air pollution. So those who are having allergic diseases, if the air pollution is very much, they have to take all the precautions. So this is a very good helping hand for us. Now it is determined by 7 pollutants: the suspended particulate matter, 10 and 2.5 micron size, sulfur dioxide, nitrogen dioxide, carbon monoxide, ozone, very important, ammonia, and lead. So after talking about the air quality index, one very important factor, very important nowadays coming up, are the epigenetic changes by the environmental pollution. So air pollution, agriculture, food, and microbiota contribute for the early immune programming in the pregnant lady and development in the fetus by the epigenetic changes. So it is changing the genes, changing the genetics. So this is very vital, very important. And these changes are the long lasting. They can affect the child subsequently till the child grows, subsequently later on in the adulthood also. So if we see this table, this diagram, this pregnant lady, the various microbiota, probiotics, and their gut microbiota are very helpful. Then the food, vegetarian food of good quality containing more of the antioxidant is very helpful. And also the farming is helpful. But the only thing which is detrimental, which is harmful, is the tobacco air pollution and also the other pollutions. So they are affecting the fetus. And it is very important because genetics is a brick and mortar, environment is an architect to bring out the allergic diseases. Now, this is how the allergy is being caused, allergic disease is being caused. There are so many allergens in the atmosphere, but they are not affecting everyone. They have more affecting those ones who have got the genetic susceptibility. So once the adjuvant factors are there, like environmental pollution, smoking, and other factors, infections, so this genetically susceptible person gets sensitized. So this is the initial step, sensitization is the first step. Now after sensitization, if there are triggering factors are being continued, like infections, irritants, pollutants, then what happens that this sensitized person gets the allergic disease. So this is the second step. But the symptoms of the disease are not very severe. But if the subsequently also we are not controlling the environment, is more exposed to the environmental pollutant also, then he will develop the severe allergic symptoms, severe symptoms of the allergic disease. So why we are talking about this? Because this is very important when we treat the child. We have to we have to treat, we have to do the primary prevention at this step, then secondary prevention, and also the tertiary prevention. So that is why it is to be mentioned here. Now, asthma exacerbations, very important. We are talking about genetic factors. There are certain genes, airway remodeling gene, ADAM33 gene is responsible for causing the allergic asthma. Then airway responsive gene, which is governed by both the maternal and paternal factors, along with the air pollutant, it also gives rise to asthma. Then antioxidant gene, very important, very vital, filaggrin gene. So with the air pollutants, it may cause oxidative stress, and oxidative stress is one of the very important vital factor for causing the injury and inflammation. We'll discuss later on, and subsequently causing the asthma. And lastly, immune response gene. It governs the Th2 phenotype, and along with the air pollution, it causes sensitization and the allergic disease. And air pollution not only stops after this, here also we can see it may cause subsequently more exacerbations, more sinus symptoms in that poor child suffering from asthma. Now, this is also very important diagram. Very important diagram. We see that the air pollutants like particulate matter, ozone, and nitrogen dioxide, along with the climate parameters on the left side, we can see the temperature, relative humidity, and ultraviolet rays. Both these, they affect the allergenic bioparticles. And allergenic bioparticles are the base. Once they are stimulated, then they liberate various enzymes. Various enzymes they liberate the PAMs and also allergenic proteins. So what happens? These enzymes, they act upon the epithelial cells. Epithelial cell is one of the very important vital cell. And once it is being damaged, then what happens? That the cells, which are the dendritic cells, are in the subepithelial area, they are also stimulated. These dendritic cells, then they stimulate the Th2 cells, and Th2 cell, with the help of the B cells, gets liberation of the IgE from the bone marrow, and IgE sits on the surface of the mast cells. Mast cells is known as the master of the inflammation, master of the allergy disease. And once it is stimulated, there is a liberation of the mediators of inflammation, and inflammatory response is there. If the process continues, subsequently, the eosinophils take over the charge and they cause a prolonged allergic disease. Now, these air pollutants, they act at many places, not only on the these allergenic bioparticles, also directly acting on the mast cells, acting on the allergenic proteins, and also directly affect the epithelial cells. So this is very important to know. We have to, the epithelial cells damage is to be stopped. This is very vital. Now, there are various risk factors for a child to develop the allergic disease, and this is maintained by a balance in the body. Now, this is known as the cytokine balance. There are certain things which are helpful, which do not promote the allergy and trying to decrease the allergy. They are the Th1 lymphocytes. They provide protective immunity, and they are helped by the interleukin 2, interleukin 12, IF gamma, tumor necrosis factor A, and also along with the other factors, other preventers. They are the natural environment and farming, cross-ventilated houses, traditional food habits containing more of the vegetarian food and more of the antioxidant food. Then presence of the elder sibling. Why we talk of the elder sibling? Because the elder sibling, if has some infection, the younger sibling gets the cross immunity, and this may help him in preventing the allergic disease. Then early exposure to various infections, then coronavirus, what the name given, Euphoria 2020, because during the lockdown, the children were not exposed to the external environment, outdoor air pollutions. Hence, the corona incidence where the allergic bronchitis or allergic rhinitis, allergic diseases were less noted because of the children were not exposed to the external environment. Then upbringing the forms, and then there are certain, we can say, detrimental things. On the balance, one is helpful, one is harmful. So what are those harmful ones? Are shown on the right side. Are the Th2 lymphocytes. They are the head of them. Then allergic diseases, interleukin 3, 4, 5, and 13. And along with them, they are helped by the various factors. They are known as the promoters of allergy. They are if the child has family history of allergy, urbanization and lifestyle changes in the urban areas, more of the air pollution, and depriving the protective germs like protective microbiota, then change in the dietary habits. Now we are switching more on the junk food and also on the non-vegetarian food, which is destroying the gut microbiota, which are helpful. So we have to consume more of the food that is having antioxidant activity. Then widespread use of the antibiotics also, they also destroy the microbiota of the gut. Then pollution, indoor or outdoor pollution, is responsible for increasing the allergy. Then environmental tobacco smoke is very important. Volatile organic compounds, very important. Cooking fuels, also exhaust. And then various viral infection, and one is cesarean section. Nowadays done more more of the cesarean section done. So when we do the cesarean section, the newborn which will be delivered is deprived of the exposure to the normal gut flora of the mother, normal vaginal flora of the mother. So hence he is not immune for them, and hence the child has less immunity and the child can suffer more subsequently in the life. Always we talk about the particulate matter and also the gases, how they affect us. So once we talk about the particulate matter, it depends on their size. The particulate matter which is having more than 10 micron, basically they confine themselves to the upper airways, up to the glottis. Then the particulate matter between 2 to 10 micron, 2 to 10 micron, they basically from the vocal cords up to the, we can say, the division of the main bronchus. And then lastly, the smallest size, 0.5 to 2 micron, they go to the terminal airways like bronchioles and alveoli and can cause the alveolitis or pneumonia, and this causes allergic bronchitis, and the upper one usually cause allergic conjunctivitis. Now similar is the in the cases of the gases how they affect. This depends basically on all these gases, their solubility. If they are highly soluble, as I discussed, they will be confined themselves in the upper airways, and sulfur dioxide is notorious. And we have seen on the Diwali season, they may cause the allergic conjunctivitis usually. Then in the medium airways, ozone is notorious to cause the allergic bronchitis and tracheitis. And lastly, the water solubility is very low, very less water soluble gases like nitrogen dioxide, they affect the lowermost airways and can cause the pneumonia or bronchiolitis. Now, various gaseous pollutants, all of them are very detrimental. Carbon monoxide, it is having hypoxic ill effects. Now, it seems it is not having effect on the pulmonary function test, but it is known as the silent killer because it combines with the hemoglobin to form the carboxyhemoglobin and subsequently causing severe hypoxia. Sulfur dioxide is the one, it has very important function that it causes. It has a very important detrimental effect that it decreases the ciliary activity. Now, epithelial cells have got cilia over them, and these cilia are responsible for clearing the mucus. So when the ciliary activity will be minimized, will be less, the mucus will accumulate there and is a source of secondary infection and also will cause more distress, more wheezing to the child. Then nitric oxide. Nitric oxide, besides causing the airway inflammation, the important thing is that it increases the sensitivity to the dust mite. So it is also indirectly increasing the indoor airway pollution. Then ozone. Ozone is very, very irritant to the respiratory tract, and it has got a cumulative effect. And it increases asthma up to the extent of 43%, very significant. When we talk of the particulate matter, it depends on their size, 10, 2.5 or 1 micron, and it is one of the major culprit. The sources are black carbon, polyaromatic hydrocarbon, volatile organic compounds, and various metals. It can cause the direct or reflex airway spasm and potentiates other pollutants. And nowadays they have found that increases the serum IgE levels. Now, what happens if this particulate matter size is very small? Even they can cross the pulmonary alveolar membrane and can reach up to the systemic circulation and can cause non-pulmonary effects. And once they reach to the bloodstream, then they may cause the extra pulmonary effects. They can cause lifelong effects on the child development by causing the autism, dementia, sudden infant death syndrome. And it has been shown that subsequently when the child grows, they may cause various coagulopathy, cardiovascular diseases, diabetes, and malignancy. So it is very important to know about that. And what is there that when the persons who are living in the cities, living in the areas where there is more traffic. So what happens? This is the traffic derived air pollution. It causes problem to the mothers, even pregnant mothers. So what happens if the mother is living in the overcrowded area with more of the traffic is there? What happens that she may inhale this particulate matter, and they can go up to the alveoli, and then crossing the alveolar capillary membrane, reaching to the maternal circulation, and even they can reach up to the placenta. And once they go to the placenta, along with the platelet, they can form the clots there. If these clots are very much in number, they are more, they can cause even the stillbirths. Or if they are less, they may cause the prematurity or small for date children. Now, the thing is that when the mother is exposed, the newborn is affected. Now, this newborn is more, in subsequent life, more prone for the wheezing, bronchiolitis, and asthma when this poor child grows subsequently in the life. Now, we have got the indoor and outdoor air pollution. It acts on the host. So it acts on the host, outdoor and indoor air pollution, and it depends on the various factors of the host, like genetics and comorbidities, and also depends what are the timings of exposure, how long the child is being exposed, and what is the location of exposure, whether it is the upper respiratory or lower respiratory tract. We discussed for the gases, whether on the skin it will cause the allergic dermatitis, in the gut also it destroys the gut microbiome and the allergy, and also it may cause the growth retardation in the children if it is for a pretty long time. And so these are the delayed effects, long-term effects of the air pollution on the development of the child. Now, how environment causes the damage? Now, the environmental pollution, along with the smoking and the physical damage, they are helped with the various pathogens and also various allergens. So all these three, they form a group and they change the environment, and then they make the host more susceptible. Now it will further depend on the how the host reacts. If the immunity of the child is good, then they are not able to damage much. So disease will be very mild. But if there are certain factors which have the immunity of the child is low, and the child will have the severe disease, so this is given the name of heterogeneity of the symptom. So this is depending on the what is the role of the interleukin. So the cytokine, if there is a cytokine storm, the child will be affected more, and the child will have more severe signs and symptoms, and may have the other also diseases, other symptoms of the disease. And this will be headed, if there is associated smoking, it will be more. And if the child is obese, we have seen in the, even in the dengue also, even we have seen in the COVID also, the obesity was one of the factors which was very much detrimental for the children for their recovery. Similar is in the case of allergic diseases. Now we see all the time we are talking about the allergy. So how it is affecting the reactive oxygen species produces oxidative stress. And mind it, oxidative stress is very vital. It causes more of the mucus production, smooth muscle contraction, increased permeability, and all the symptoms of the inflammation and allergy. And the very important is that it causes epithelial damage. Cilia are being destroyed. And the children who are exposed daily for 1 to 2 hours to the environmental pollution, it takes about 1 month, complete 1 month for the recovery of the functions of the cilia. So it is very much stressful. But under these conditions, how we are surviving, how the child is surviving, because it is maintained by a balance. Now, for all reactive oxygen species, there are certain in the body also certain things which help us. It is the friend, our friend, helping hand is the pineal gland, situated between 2 hemispheres of the brain. And it has been given the name of third eye of Parmeshwar by Dr. Parmesh sir. So melatonin is being secreted by the pineal gland, which is regulating the sleep-wake cycle. And also this melatonin is very vital, very important. It is protecting the child from the cell damage, from the free radicals. And this has been given the name of antioxidant effect. Also, it regulates the puberty, and it requires only good nutrition, good we can say that the good diet, antioxidant support for its proper function. So this is the helping hand for us. Now, every time we are friends, every time the parents are coming, my child is getting the allergy. Sir, my child विंटर में भी एलर्जी थी, इसको बारिश में भी हो रही है, गर्मी में भी हो रही है, जब भी सीजन बदले क्या करें? Now, because they are correct, because every season there are some allergens. We don't know to whom the child responds. Increased temperature, summertime, and allergy, asthma will increase from ozone formation by emission of the automobiles and volatile organic compounds in presence of the bright sunlight. And in the global warming, allergy is also increased because carbon dioxide prolongs the flowering season, and it prolongs the symptoms because of the pollens. Now, one thing is very important during the global warming, the trees are stressed, and these stressed trees are very harmful. They are given the name of potent pollens, and the diesel particles are getting coated on this pollen produced by the stressed trees. And these diesel coated pollens are 50 times more potent to cause the allergic disease. Now, the third factor is change in the humidity and season. Increased humidity and warm temperature increases dust mite allergy. Decreased humidity and increased temperature increases pollen allergy. And decreased humidity and decreased temperature increases fungus allergy. Now, continuing with that, the under wet condition during thunderstorms, the grains, they rupture by the osmotic shock and release their contents into the atmosphere, causing more of the allergy. During the drought also, asthma and allergy were triggered because of the more dust during the drought and more smoke from the wide forest fires. Now, nowadays, very important, diesel exhaust particles. Diesel, mind it, for the air pollution, this is very detrimental. Diesel exhaust particles, their important functions are, important thing is how it affects, that it causes a neosensitization. The person who was previously not allergic will become more sensitive to the allergy, and then it also stimulates IgE synthesis. Then environmental tobacco smoke, it is an adjuvant for the IgE induction and increased circulating eosinophils IL-4 and IL-10. Now, diesel exhaust particles, they cause, along with the particulate matter, they cause a reactive oxygen species. Free radical oxygen is being produced and causes inflammation. Very important, because of the diesel exhaust particles, they affect the epithelial cell permeability, disrupting the tight junction, as we discussed. So this is very vital. And diesel exhaust particles nowadays are causing epigenetic effects. And also, along with the cigarette smoke, diesel exhaust particles induce the remarkable, very detrimental epithelial damage. So diesel is very important nowadays to see for the toxic effects of the diesel for causing the air pollution. Now we are coming towards the end. Now there are certain things, certain factors which is more prone. Yes, the children are more prone, because in children the immune and antioxidant defense is in the developing phase, and they have more respiratory rate, they breathe in more air, breathe out more air, so they are more exposed to the environmental pollution, and they are spending more time outside to play. Now we are talking of the period which was not of the lockdown, so most of the children were playing outside in the evening, also going outside, more exposed. And also, if there is any comorbid conditions like obesity, it is very important factor. Then the lifestyle, we always say lifestyle changes should be there. The urbanization, mode of transport, living in the high-rise building, and poorly ventilated houses. Now, this is showing that there are some microbiota, gut microbiota, lactobacillus, bifidobacterium. They are very helpful because nowadays there is a gut-lung axis which is providing us immunity against the allergy. But on the other hand, the respiratory microbiota, the respiratory, we can say bacteria, they help to having the pneumonias, atypical pneumonia. So the gut microbiota are the helpful for the body. Now, in every asthmatic patient, Dr. Nagaraju sir and Dr. Parmeshwar always used to say, always take the history. Only history gives you to the conclusion most of the time. When this is more important during the flare-up of the disease, or in the poorly controlled patient, always take a detailed history, and all the asthmatic children living in the urban areas, because they are more prone for the allergy. Now, also, we have to change our treatment. When? Because if the allergic rhinitis is not controlled with the routine medication and air pollution is there, then we may need a step-up therapy. Then the use of the antihistaminics has shown very good response in presence of air pollution. And lastly, intranasal corticosteroids, if they are added in the presence of air pollution, they give the excellent response. Investigations minimum. Measures of inflammation, fractional excretion of nitric oxide, FeNO, and functional assessment by spirometry or impulse oscillometry. FeNO is surrogate marker of eosinophilic inflammation and corticosteroid sensitivity in bronchial asthma. If there is an increase in the particulate matter of 2.5 or 10, there is also increase in the NOT levels, and this shows higher FeNO levels. So this is the importance. Now, counseling, very important. Always talk about all the family members, air quality to all the patients with the asthma, allergic rhinitis, and chronic lung issues. Always counsel on the preventive aspects. Prevention is always better than cure, and re-evaluate the treatment strategies based on air quality if the child needs any other drug. Now, this is the last slide and the very important slide. What we need to reduce the air pollution is the quality education of all the stakeholders. And I'm glad to inform you that Dr. Parmeshwar had a meeting with the government officials for giving this quality education to all the stakeholders, and the process is going on. So how it will help us? By reducing the pollutants at the source and also eliminating the emission and protecting the affected. Now, reducing the pollutant at the source by setting certain guidelines, regulating the automobile. So whenever someone is purchasing a new vehicle, always confirm whether he has the sufficient parking space or not. Otherwise, if he will park the vehicle outside on the street, this will cause more of the air pollution, more of the congestion. Then new energy sources like the nowadays electric cars are coming. So that is one. Hydraulic energy should be used, and also the we can use the this atomic energy also can be used. The solar energy can be used. Then reduce the fossil fuel. It is very important. Now, second point is eliminating the emission, increasing the greenery. The trees are our friends. They give us oxygen, take carbon dioxide from us. So every time plant a tree. So nowadays we are doing that on every birthday, we are planting one tree, taking care of that every year. So there should be one tree per person, or even one tree for 4 family members. This also suffices. Ocean agriculture for increasing the greenery. Sustainable cities should be there. Nowadays, there are more in the cities, more of the people migrating from the villages to the cities, and cities are becoming overcrowded. So we should consider that point also. Equate demand versus supply, population growth should be controlled. And lastly, protect the affected. This is very important practically. We have to treat the child. traditional food habits are very important, because vegetarian food only will give rise to carbon dioxide 1 kilogram to 1 kilogram of the carbon dioxide. On the other hand, non-vegetarian food, 1 kilogram will produce about 22 to 24 kilogram of the carbon dioxide. So this is causing more of the air pollution, the non-vegetarian food. Then good ventilator houses should be there, and that safety controller medicine should be prescribed. Now in this, Dr. Parmesh sir always says that those medicines should be prescribed which are acting on the ciliary activity, peripherally acting. They should be more promoted rather than the centrally acting. And then research to our need, we need more research how the diesel exhaust particles they are affecting, how the volatile organic compounds are acting, how they are causing the allergy. So this needs more of the research, and we have to, all these points should be coordinated, should be incorporated in our action. And if we need the help, then the legal activism can also be taken help of. So what, friends, we have to combine together, join together and act. We should think locally, act locally, and propagate globally to achieve our target of healthy child, nation's pride. For this, at individual levels also, we can do many things. And Professor Pramesh sir has given very good guidelines at individual level what we can do. That try to live without a car, try to go more on the bicycle, then electric car should be promoted, then avoid a very long air journey. Suppose we want to go to the two places in the Europe and other Asia, so we should try that only in one journey we can go to the two places. Then solar energy, hydraulic energy should be used. Then the renovation, because in renovation we should take care that the Vastu considers the adequate sunlight, adequate ventilation. So that should be taken care of. And vegetarian diet should always be promoted, containing more of the antioxidants. Then the LED lights should be used more because they cause less air pollution. Then improved cooking equipment should be used because they will decrease the environmental smoke, should be minimized. Then the renewable based heating should be encouraged. Then the lights and fans should be off when we are not using. And lastly, we should not use, and we are not using, the crackers should be minimally used, and even possible it should not be used because they cause very detrimental environmental pollution. So I will end with a special thanks to the Sanofi India for their unrestricted educational grant, and also because they are helping us to plant more of the trees, and they are helping for the proper growth of the child, saying no to the sedating antihistaminics. Once again, I will request that daily, yesterday also I said that our message should be multiplied, not added. And this will help us. For Professor Nagaraju sir, his mission was that this allergy module should reach each and every doctor at every corner of the country, and we are all doing work in that under guidance of Professor Parmesh sir and also Dr. Sukumaran sir, and with the help of all the president, the Dr. Piyush Gupta sir, Basav Raja sir, Ramesh Kumar sir, and Bakul Parikh sir, and also with the guidance of our North Zone Vice President, Madam Sangeeta Yadav, and also Dr. Upin Narayan Reddy. I will once again say, he is doing a lot of work for that, and he's taking the lead. Myself and Dr. Jose, we are helping him, and I want the support of all of you. You are very powerful and very active. So please try that this message should reach each and every part of the country. Thank you very much for the patient listening. Thank you very much.
Thank you, Dr. Devinder Sareen, for an excellent talk. It was a long talk, 40 minutes, and you took so much of efforts with so much of energy in your talk that every word was like a positive thing. And just to highlight what all you said, in a nutshell, you talked about indoor and outdoor pollution, gaseous and particulate matter, and their impact on respiratory system and other diseases also. And also you talked about the impact on the fetus. I think this is a very important thing which we are not realizing, impact on the fetus and subsequent problems after birth also. You've talked about the pineal gland. We'll ask Dr. Parmesh later to expand on it a little later. And you talked about the weather changes also and allergic diseases related to that. And diesel exhaust particles, I think this was a very important one message, that if all of us who are driving, if we give up on diesel cars and come on to the electric ones, that will be the boon, and this will be a blessing again. And other vulnerable groups like children, I think we have to. And another interesting thing you talked about was the gut lung association. And I'll request Dr. Parmesh to expand on that also, and make us little more wiser onto that. And measures about reducing the air pollution, you've talked about that. And finally, the wits from the experts. I think these were the gist which we have given, the wits from the expert, how we can reduce. Thank you very much, Dr. Serene. And over to Dr. Manish, Dr. Sangeeta, and Dr. Parmesh for further comments. Thank you very much.
Thank you very much. Excellently delivered by Dr. Devinder Serene. With so much passion and commitment, he had given this whole presentation, that it really has had impact for all those who were listening, and how all this can be translated into clinical practice and practical aspects which were highlighted by him. And it's kind of the after effects and how it is going to affect the epigenetics and the future generations. That was the most important point about it. And Dr. Vasudev has beautifully summarized all the material, that scientific material which was delivered. And I'm telling you, these slides are superb. The way all the scientific material and the explanations have come out in on the whole module, it's really worth it, especially for the younger generation to attend and to learn so much from it. So that is the best part about this module. And very rightly said that Dr. Parmesh is going to give us the expert opinions, as well as enlighten us further to the various aspects which have been flagged off by Dr. Vasudev. Thank you. Thank you very much.
I think, Dr. Gita, thank you very much. You already mentioned the one of excellent talk. You can see his commitment, how he expressed all these things, ideas. Really, I agree 100% with you. And all our friends, I think gut and lung axis, skin and lung axis have taken priority now. That's mainly from the mast cells. From here, if we get to even if what you call anaphylaxis, if we have, you don't have to eat food. It can come from the inhalation. It can also come from the contact. If you're allergic to some food, if you touch the food, you might develop anaphylactic reaction from skin to lungs. And same way, gut macrophages, and I mean the immunological cells transfer from here to the bone marrow, and most of chemical mediators in the lungs will be produced. So gut microbiota is very important. They control this thing because we have about 10 germs per cell. So majority of them are protective. That's why we don't want to use unnecessary high-powered antibiotics, small infection, newborn babies, and all these things. So you don't want to kill the microbacteria. So because the muscle man of the immune system is very much important for us to maintain it. That is the axis has been there. Now, recently, I want to tell, our government has committed in this one, in the Glasgow meeting, what we had, it just ended. And we have taken to, because 95% of the pollution comes from the fossil fuel. Coal is the number one. Next comes the petrol and diesel. And burning of the agriculture waste and other waste is only 1%. That too, this season is very high. If the wind is there, it will go away. But cement is 3%, as a matter of fact. And health-related issue, our nursing homes, hospitals also contribute. So 4.3%. America contributes 15% of the global warming climate change. This we have to look into that aspect, health-related issue. Our hospital, nursing homes also pay attention to that. And recent observation has done that Himalayan glaciers are dissolving. That is a thawing of the thermofrost. When the thawing of thermofrost happens, greenhouse gases going to increase by 20 to 30% because all the sand, dust particle, small particle was intagnate that one. They will come out. The pollution also becomes more. Global warming becomes more and more. That's one thing. And also, on a 22,000 feet above sea level, they were identified that by ice core, removing the ice core, various carbon particles will be there. That also becomes more and more. And also, they have identified 33 new viruses, 28 of them new viruses. And also, infection disease, one might think about coming back in the future. Pandemic going to come. This observation not been say COVID is also mainly issues. We have created that. I think I'm bold enough to say, make that statement. So with all these things, new WHO guideline has come where we have to reduce further to decrease the carbon dioxide and decrease the global warming to the tune of keeping the temperature 1.5 degrees end of the century and keeping the carbon footprint almost 250 part per million. I think new guideline is the 20 to 25% reduction will be there for pollutants. We have to aim for it as much as possible. I am proud all the countries are agreed. Only financial aspect they're working on that one. I think we are able to come out of this one. The leader like our countries have it. We could be able to achieve it. And thank you very much propagating knowledge all over. And again, I have to Devendra Sarin, you have done a wonderful job with putting your heart, what you are talking about, making the people very feel proud and hear you again. God bless you. Take care. I think we are going to achieve this one. We are going to save this earth. We are going to live comfortably. Thanks for our country taking the lead in this context.
Thank you, sir.
Thanks again for giving me the.
Thank you, sir. That was a wonderful guidance and comment for this final word on the air, allergy and air pollution. So there are few questions and I expected this. The major question is regarding the use of air purifier, one-line guidance, air purifier at clinic, office and homes. And if required, what particular one?
Dr. Parmesh sir is there, is my guiding force. So I request Dr. Parmesh sir, please.
Okay, I think they definitely work. They don't clean the air. Air cleaning, everything like that, they don't clean the air. As a matter of fact, they can reduce certain extent. And also smell can be changed. But definitely, if a complete air purifier, if you put it there, they will absorb certain particulate. They work in different way. Majority of them, they produce ozone. If you don't maintain properly, the ozone can increase. They can produce more harm, as a matter of fact. So that point we have to keep it in mind. Most of them have to be tropicalized and related to our pollution level rather than Western country pollution level. And cost also should not be unnecessarily wasted, as a matter of fact. In addition to that, we want a natural way of the air purifier. Please have indoor plants. There are about 10, 15 indoor plants are there. The nature has given that one. They absorb the carbon dioxide, formed volatile organic compound, and also they give enough oxygen also. But make sure they expose to sunlight once a week, remove the tray of water once a week. This is what we have to do it. I think it does work. If you have enough funds, please use it, as a matter of fact.
Excellent, sir. I think very excellent advice, very balanced advice. Thank you,
How
sir.
to reduce the ozone levels with the air purifier?
Because the air purifier starts the production of ozone also. They produce.
Yeah.
So if you don't maintain it, ozone production can produce air. It has got a cumulative effect. So it can produce airway inflammation.
So you mean good maintenance is required whenever we are using the air purifier?
Yeah, most of these have been done. with the Western pollution level, not our level. Delhi level is highest, as a matter of fact.
Yes.
And hats up to you, God's grace, we're all living in that one. Believe me, sir. Okay.
Dr.
And this article, yeah, go ahead, sir.
Dr. Paramesh sir,
Yeah.
does this wearing N95, though we are wearing mainly to prevent against COVID, does that also help a lot against particulate matters also?
Particulate matter, 95% it can do that. It cannot really 100%, it won't work.
Right, sir. Dr. Sangeeta madam, Dr. Vasudev sir, shall we
Even
go
our
to the next
surgical
section?
mask, would they not be enough surgical mask, 3-layer surgical mask to reduce the particulate matter? Because these N95 masks, when we wear, after a couple of hours, we start getting headache. There's so much of accumulation of carbon dioxide. By the evening, we just feel like throwing it away. They're so obnoxious. When I sit in my car, the first thing I do is just remove it, take few long breaths. And these 3-layer surgical masks, I think when we are moving outside, they should be enough for reducing the particulate matter inhalation. What's your comments, Dr. Parmesh, about it?
I think I agree with you, because these masks don't really, carbon dioxide be 20 times faster diffusion. That won't happen as well. Less oxygen might sometimes happen. As a matter of fact, airway resistance increases. Airway resistance causing the inhalation becomes a problem. Sometimes fog-like, if you're wearing a glass, fog-like thing will come out in exhale. That causing a lot of problem. I think little connection is 100% you cannot protect it. I think if you have 2 doses of vaccine, if an arm distance, you don't have to wear it, as a matter of fact. When you're walking, anything like that, if you keep arm distance other person, you don't have to wear it. It's only, as a matter of fact, it has come earlier, any pandemic, they said you have to wear the mask only if you have a disease, H1N1, or if you're going to take a H1N1, you have to wear it. Otherwise, you don't have to wear it unnecessarily, causing fear, whole lot of things. That, as a matter of this, social has become so much now, everybody fear created wearing mask all along. But this WHO guideline changed later on, as a matter of fact, because of that. Now there is a guideline, you don't have to wear it unless, if you have a breathing problem, I don't think you should wear it. Make it the looser one, as a matter of fact.
There's a comment by Dr. A.K. Sharma in our chat box that N95 contains plastic and detrimental to environment. For COVID or short term, it is okay, but for long term, we should not propagate as a daily wear and continuous wear for everyone.
I think he has a point to say that, sir.
Yes.
I had to look into that angle.
Right. Thank you very much, sir. And Dr. Manish, I think if there are no more queries, we can go ahead
Right,
with the
sir.
second talk.
Sir, can I say one story, sir? 1 minute. Can I take 1 minute?
Please,
Go
sir,
ahead.
please.
Madam, what happened when there was sudden demise of Dr. Nagaraju, sir? I and Dr. Upinarayan Reddy, we talked together and we were very much disappointed how to continue with this module. And both of us telephoned Dr. Parmesh, sir, and it was the night time. And then he reassured us, don't worry, I'll be there to guide you. Keep on continue. And madam, with his blessing, every Saturday, Sunday, we are getting this module. Most of the India we have covered. And I always want the blessings of Dr. Parmesh, sir. In future also, sir, please keep on guiding us for this. Thank you, sir. Thank you.
We are honored, sir. So my God, you are doing a wonderful job. God bless you all. Thank you. Thank you, Dr. Sangeeta.
Thank you, sir.
Thank you. So nice of you. Okay.
So thank you, Dr. Vasudev sir, Dr. Sangeeta Yadav madam for chairing this session, and thank you, Dr. Devendra Sarin sir, for excellent delivery of such a nice session, and Dr. Parmesh sir always guiding us, sir. So now we move on to next session, the main heart and brain of this CADE module. And over the time, we have learned so many in last 2 decades from Dr. Nagaraju sir, and we all miss him. And I would request our senior members, Dr. Sangeeta Yadav, to introduce Dr. Nagaraju sir, and then we can have a recorded video talk of Dr. Nagaraju sir.
Thank you, Dr. Manish. We all know Major Nagaraju. Um, he was professor at the Ramachandra Medical College in Bangalore, in Chennai, sorry. And he had a passion for pulmonology, allergies, and then he left the army and he started working in this medical college. And then because he was very much influenced by the fact that these allergic issues have to be addressed and to be tackled. So he had started with his in his institution related to the allergies, skin testing, and he took it forward. And plus he used to conduct workshops, and he also got some courses also recognized related to this. And I know him as in IAP as an EB member, and also he was vice president with me. And it is really a great loss to the academy with his sudden going away. And he was totally a dedicated and a passionate person. And he has written a lot of articles and presented a lot of papers, not only in the national but also in the international arena. And he has published books also and contributed towards various chapters also in the books. And he had a lot of scientific bend of mind. And he used to encourage publications as well as the scientific tenor. And with these words, we move on to listen to his recorded presentation related to skin allergy testing. And from that, we all are going to learn how we need to put it into our clinical practice. Thank you.
Khushi, we can, yes.
Yes, sir. She has shared it.
Yes.
Good evening. I am Dr. Major K. Nagaraju. I am the professor head of the Department of Allergy and Clinical Immunology and also Director of Fellowship Program in Allergy and Clinical Immunology, Savita University. I am also visiting.
Khushi, volume can be increased, some volume, if possible.
And also the Vice President of the Indian Academy of Pediatrics, South Zone. I am going to talk on today allergy testing, especially skin testing. I am going to talk.
Is it okay?
Before that, going to the topic.
Yes, sir. Volume is quite good.
What is allergy? A lot of people ask. Any foreign substance enters into the body, that is the antigen, what we call it as. In Greek, we call it as allos, means altered. Ergos means response. You will get 3 responses. There is no response at all for any body enters, so that body is not reacting. And body react to that, and you will get immunity, you will get immunological response. Whereas other thing is that excessive immunological response you will get, that is called hypersensitivity, that is the allergy one. What is the real meaning of allergy is the aberrant or excessive immune response generated against the foreign antigens. This is the one thing. Allergen means it has to be a protein. It has to 5 to 180 kilodaltons has to be there to raise the antibodies against that. What are the allergens? These are the allergens, mainly 5 allergens. That is, dust mite is very common all over the world. And in India, it is about 70 to 80%. Coastal district is about 80 to 90%, whereas other places 60 to 70%. Second one is cockroach, and third one is fungus, and pollens are very common in different places. Pets, depending in India, it is not much common. Now we are seeing more and more cases of pets also. Food and drugs and venom is another things. The family history of allergy will be there. Father, mother, whoever may be suffering, or a child has got atopic dermatitis or allergic rhinitis, a weak child, you can suspect allergy. When a patient with allergic rhinitis, most of the people won't come with saying that I am suffering from allergic rhinitis. Most of them come with permanent cold or recurrent cold or cough, throat pain, sneezing or rhinorrhea. This is the main thing. A lot of people will come. With that, we have to think about when there is a throat pain is there, you have to look for ear pain is there, ear also involvement is there, sinus involvement are there. All the things together, you can suspect the allergic rhinitis. When to suspect allergy? Any patient with wheezing, there is a urticaria with or without angioedema suspecting allergy, and dry skin, atopic dermatitis, and allergic conjunctivitis. Any rashes or arterial rashes or angioedema, or you develop anaphylaxis within 2 hours after taking food or drug, can able to think about allergy. And there may be some people complaining of ear itching, throat pop, ear popping, and fullness, and all these things. That is otitis media effusion will be there. And repetitive sneezing, allergic rhinitis, rhinorrhea, nasal block will be there. Anaphylaxis, one thing, and diarrhea, vomiting with abdominal cramping after taking a suspected food. These are the things. Some of the things, all may not be. All we cannot write all the things at a time. Some definitely we focus here. Diagnosis of allergy mainly by clinical. You have to have a good history has to be there, and your aim is to establish a hygiene-mediated disease. This is a very important thing. Good history supported by physical examination is the cornerstone of the diagnosis of allergic diseases. You have a suspicion unless your brain has got knowledge, then only your eyes can see. You have a focused allergy questionnaire to given to the patient. Patient always go through that thing and correct it so that we can able to go through that questions and we can suspect it. Test will not only give you supportive diagnosis only, but also is a confirmative so that we can able to allergen avoidance or immunotherapy may be helpful. So the combination of typical history, compatible physical findings, and positive tests only gives you the probable diagnosis. So what are the diagnostics? That's the only we call it as a diagnostic pyramid. Medical history and physical examination is the cornerstone, I already told you. Then with the history and all proper tests, you have to go for in vitro testing, that is in skin prick testing or intradermal testing, which I am going to talk to you later. Almost intradermal testing is now outdated. Only certain places like drug allergies or venom allergies only we are using. In vitro testing, it has become very popular nowadays. All over the world they are using. Those people not accustomed to skin prick testing, though it is less sensitive than skin prick testing, that is specific IgE testing. Nowadays, most of them are immunocap. A lot of people are this technique. A lot of people are using, and most of the people not doing the allergen challenge test except nasal challenge and bronchial challenge, conjunctival challenge. Rare cases they are doing. So prick test is a very, very preferred technique for diagnosing IgE-mediated diseases. History is very, very important, and you have to know about the history in the skin test before it. Specific clinical history of the patient, to have a good interview with the patient. What type of the disease and duration of the disease, severity of the symptoms, and what are the affected organs you have to take up in the history. Current history, past history, medical, what medicines taken, family history, environment, all will help you to pick up what type of test you are going to do it, allergens you are going to do it. And known or suspected local or regional indoor allergens, outdoor allergens. So indoor allergens means dust mite, cockroach, and all. Outdoor allergens, pollens. By history, you can able to know it. I will give you one example. A child, a 5-year-old child, there is no point of doing outdoor allergen. Child cannot go out to do the pollens at all. So he is the indoor. A mother, what is the occupational history also very important. Mother who is working lady who is working in the kitchen and looking after inside the house only, most of them are indoor allergens we have to look for, especially cockroach allergies. You have to think about this. Knowledge of foods, what foods they are eating, food allergens, food chemistry, you have to know about that. And knowledge of cross-reactivity and local area, what are the your pollens available in that area, you have to know about. Natural history of the disease process also, you have to know about that. Different tests, which one to choose? A lot of tests are there, skin prick test, intradermal test, ubiquitous patch test, you can call it, atopic patch test, which one to take? In and allergies, prefer only skin prick test. And food allergies also skin prick test is preferred. Whereas venom allergies and drug allergies, intradermal tests are preferred. And the contact allergies, that is contact dermatitis, where you can do patch tests. So these are the tests, whatever I told you already. And vitro, these are the total Ig levels also nowadays is lower diagnostic value and clinical value. And component resolved diagnosis, now only it has come to India, only we are the only center we are doing, no other center is doing. That's why I told currently not available in India, I went all over the India only. We are the only people in our center only we are doing it. Which test to be select for Ig-mediated allergy? I already told you there are two types of in vivo test and vivo test. Out of this, which one to select? There are definitely, you know that thing, skin prick test, intradermal test, patch test, and challenge tests are in vivo tests, and in vitro tests are total Ig and specific Ig, serum specific component resolved diagnosis. Component resolved, though it is not available India all over, but we got with us. Which one to choose is very important, because intradermal causes anaphylaxis and specificity is very low, and patch test only for contact dermatitis. Specialized centers only they are doing challenge tests. So which test to be choose is very important. Now you see that all the other tests, only skin prick test and blood test, serum specific Ig is only thing to be taken, because that is the only thing out of these two. Skin prick test is gold standard. So for detection of specific Ig, there are two tests I told you already, in vivo test and in vitro test. In vivo test is skin prick test. It demonstrates the antibodies fixed to the mast cells. Specific IgE antibody fixed to the mast cell underneath the skin, we can able to demonstrate. It can be present as a wheel. You can able to see it here. And it is a gold standard. It can be performed by small children also, mainly because it is very highly sensitive. Whereas in vitro test, that is the mainly thing, immunocap, most of the people we use it nowadays. Previously it's called as RAST. It's only, it demonstrates the circulating specific antibodies in the serum only. That's why skin prick test is a gold standard. Coming to the same thing here, you see that it is fixed to the mast cells here. It is freely circulating here. We are measuring it. This child, Shaktipriya, 14-year-old, has come with a recurrent anaphylaxis with urticaria angioedema whenever there is there. She was admitted several times in the hospital, medical college, where she was all the time is received with, revived with adrenaline. When they came to us, we have waited for 14 days because anaphylaxis, most of the cells will be gone. That's why we have to wait for 14 days, histamine and other things. And we found that skin prick test is so big. That is the one thing what is important, gluten. So we diagnose a food-dependent exercise-induced anaphylaxis in these patients. So skin tests are also very useful. Why you have to do only SPT? Why not other things in the allergic testing? Because most of the allergic diseases are progressive. What is the meaning of progressive? It starts with mild and then to moderate and then to severe after a long time. And also requirement of drugs will also go up and severity also increases. It is also useful to find out the cause. So once you know the cause, you can possible for avoidance. If not avoidance, you can plan for immunotherapy. If everything is negative, immunotherapy, if any SPT is negative, then you can plan for pharmacotherapy, either by Montelukast or anything in case of asthma. If it is positive in asthma, definitely it may be due to eosinophilic type, may inhale corticosteroid. It guides the pharmacotherapy also, these results. What are the indications for that? Several indications are there, mainly allergic rhinitis, rhinosinusitis, conjunctivitis, allergic asthma, suspected food allergy. Patient will come, I got this so many foods like that, they'll say, but perceived food allergies are very common in children. Acute, intermittent, and recurrent urticarias, oral allergy syndrome, suspected food allergies, latex allergies, venom allergies, and also in atopic dermatitis. As far as the allergy, respiratory allergy is concerned, allergy tests are useful in allergic rhinitis. All types of intermittent or persistent, mild or severe type you have to do. Whereas In asthma, uncontrolled asthma is a contraindication for allergy test. But one control means then you can able to do it. Certain times you cannot do the skin prick test. That is chronic category without allergy history. Some people will do for food tolerance that not supposed to be done at all. Non-specific skin rashes, migraine headaches, and a lot of behavioral problems like autism, ADHD, chronic fatigue. People will do normally not supposed to be. Screening for a lot of patients will come. Let me know what are the allergies for me. That you are not supposed to do at all. And irritants, a lot of people will come with perfume, mosquito repellent, agarbatti. These are all the irritants only. It's not allergen, so you cannot able to do it. Some people you do for the allergen specific immunotherapy effectiveness, but not to be done at all. It's not going to give you anything at all. Testing for food allergies, coloring agents not to be done, and non-hygienic food allergies or drug allergies, no, not at all indicated. What are the contraindications? Severe dermographism, you can see that dermographism is here. And severe dermatological conditions like atopic dermatitis, that type of things, and burns, whatever may be in the skin, that area you cannot able to do. Whenever you inject the negative control, that is saline, you will develop a wheel that indicates the patient has got dermographism, you cannot able to do it. Patient unable to seize the antihistaminics or other interfering drugs to the skin, a skin prick test, then it is a contraindication. Immediately after anaphylaxis, I already told you, you have to wait for 2 weeks to do. Whenever you do the skin prick test, take the consent from the guardian or a parent if it is patient is less than 18 years of age. That is very, very important. If no parent, mean either father or mother, both are equally, you can take from both of them. You must explain that risks and benefits of the performed skin test to the patient. All the time you have to tell.
खुशी खुशी नेटवर्क प्रॉब्लम है
Some issue.
खुशी
Yes, sorry, doctor, for the interruption. I guess some network issues from my side. I will start again. Okay.
स्टार्ट करो
Sorry.
थैंक यू
Oxygen saturation, you have to know, and examine the patient for chest. Any wheezing is there, and peak expiratory flow also very useful, so that we know that if it is there wheezing, you have to treat the wheezing, and then only you have to do that thing. Certain medication to be avoided, I already mentioned. What are the medications? Antihistamines in general 4 to 7 days, and tricyclic antidepressant 4 to 7 days, especially ranitidine, famotidine, and cimetidine for 1 day. And topical steroid, those who are using more than 3 weeks when there is skin test is going on, must be stopped. So that then only you can able to do that thing. There is no need to stop the montelukast or any inhalers or anything. Local allergens for long term cannot be used, but at that time mild means wheel can be will not be affected, but flare can be affected, but you can use it in some patients. What is the principle of skin prick test? Here you see that when you are doing in the skin volar aspect of the forearm you are doing, we are injecting 0.001 ml, very, very little amount into the epidermis, which is a non-vascular superficial dermis. When you inject into that, it will interact with the specific Ig bone to the mast cell and reaction will occur. What is the reaction? Wheel and flare reaction by due to histamine other mediators. We can see within 15 minutes. Histamine reaction, that is positive control, we can see in 8 to 10 minutes. Whereas these allergens can be seen up to 15 to 20 minutes. So you have to wait up to the patient for 20 minutes. Then you have to see the reaction. Depth to be how much you introduce, the depth is very important. You have to go up to 45 to 60 degrees angle, 0.5 millimeters. Where we can do skin prick test. Most of the times we prefer volar aspect.
Again, there seems to be an issue.
Yeah, again the connectivity is lost. Khushi, are you there? Hello.
I don't see DIP host here.
Khushi, again there is a problem.
She herself is not on this panel.
Yeah, the connectivity issue is there too with her. I think she is.
I think it is because she is relaying it. Manish, she is relaying that.
Yeah.
Now you are the host actually, sir. Dr. Vasudev, sir. Do we have that presentation with you, Dr. Vasudev, sir?
No, I was not sent this presentation.
What do we do, Dr. Sangeeta madam, Dr. Devinder sir?
Yes. एक बार मैं डायरेक्ट बात करता हूँ फोन से ना उससे कुछ.
Okay.
I just stopped.
I think उसके network की problem है because she is not on the panel itself, so she has lost connectivity.
हाँ, अभी फिर रुक गई है ना खुशी?
She's saying something.
फिर हाँ डॉक्टर वासुदेव सर को भेज दो, वासुदेव सर को, है ना? ओके, अभी भेज दो. ओके.
So in the meantime, we can do the next presentation and then.
I think ऐसे कर सकते हैं. We can go ahead with the next presentation.
और उसके बाद में सर जो बच्चे आपके पास सर भेज रही है वो ना डॉक्टर वासुदेव सर के पास presentation.
And from there we have left at that skin testing. Antihistaminics to be stopped.
Number slide number कितना था? Slide number.
So there was 14 minutes left.
1-4.
वो दोनों चीजें अपन कर लेंगे सर. ठीक है. 14 minutes and वो medicines to be stopped.
I think we move on to the next session till those slides come. Yeah. So now I, with permission of Dr. Vasudev and Dr. Sangeeta madam and Dr. Devendra Sarin sir, I invite for the next talk on chronic urticaria, Dr. Ajay Gupta. Dr. Ajay Gupta, whom we all know is President IAP East Delhi and is a Central IAP Executive Board member from Delhi. So, Dr. Ajay, please.
Thank you, Dr. Manish. Good evening, Dr. Sangeeta Yadav ma'am, Dr. Lalit Mahendiratta sir, Dr. Devendra Sarin sir, Dr. Vasudev sir. Let me share my screen. So, though this was supposed to be the last talk, and we are now going to discuss about the chronic urticaria. Whenever the allergic condition lasts for more than 6 weeks, then it is known as chronic urticaria. Can you see my screen? My screen is visible?
Yes.
Yes.
Go ahead.
You are
So it
audible
is
also and visible also, both things. Well.
Thank you, sir. Thank you. Urticaria is a condition which is characterized by the development of wheals, that is hives or angioedema. So how do we differentiate between the wheals and angioedema? Wheal is a central swelling of variable size surrounded by reflux erythema, and there's an itching or sometimes burning sensation also. It will be of a fleeting nature. That means they keep on disappearing within 30 minutes to 24 hours, and they may reappear at different places. As you can see, they have a very varied pattern. And in cases of angioedema, it's a sudden pronounced erythematous or skin-colored lesion, swelling of the lower dermis, subcutaneous or mucous membranes, and they may be sometimes, it may be painful rather than itchy condition. And the resolution is slower. It may take up to 72 hours to resolve. And it can frequently interfere with the child's ability to participate in daily activities, disrupt normal sleeping pattern, causing emotional distress because there's lots of itching which is involved, and thus impacting negatively on the learning, cognition, school attendance, and the academic achievement. This can lead to major dysfunction within the family unit and substantially impair the quality of the life of affected child. It is mediated by histamine and other mediators released from the activated skin mast cell, which result in sensory nerve activation, vasodilatation, plasma extravasation, and cell recruitment to cause urticarial regions. And this leads to formation of the wheal. The lifetime prevalence is about 9%, and chronic urticaria develop in 1/3 of these patients. The prevalence of chronic urticaria varies from 0.5 to 5%. There is a higher female predominance, and it is more common in the adults. Females are affected in the ratio of 2:1 as compared to males, and it is highly more prevalent in the atopic population. So urticaria can be acute when the symptoms last for less than 6 weeks, and it can be chronic where the symptoms last for more than 6 weeks. It can be inducible urticaria when we know the exacerbating factors. These can be either physical or non-physical. The wheals can be reproduced on exposure to such factors, and it can be chronic spontaneous urticaria, which accounts for about 75% of cases of chronic urticaria. These can be either chronic spontaneous autoimmune urticaria. This is mediated by the IgE or high affinity IgE receptors, or sometimes it can be idiopathic also, which accounts for another 60 to 70% of the chronic spontaneous urticaria. So let us come to some case studies. There's a child about 11 years develops papular pruritic rashes after coming from playing. Another child who is about 5 years develops rash after taking hot shower. And another adolescent about 15 years who develops rashes after swimming in a swimming pool. So what do you think these are the inducible kind of pictures of urticaria where once they come in contact with some either physical agent like hot water or swimming in water, or once they are doing physical activity, even that can trigger, as in the first case where the 11-year-old child develops papular pruritic rash after playing because it involves physical activity. And another child who is carrying the school bag on the shoulders, they develop rashes which cause more pain rather than the itching, and it disappears during the school vacations. So any symptomatic dermographism, triggering factor is stroking, scratching, pressure, delayed pressure urticaria, application of pressure for 30 minutes to 12 hours before the onset of the symptoms, and cholinergic urticaria, which is induced by the elevation of body temperature with exercise, hot water, strong emotion, spicy foods. Rather than, there's no allergy to the food, but only being the spicy food can trigger this. Cold contact urticaria, exposure of the skin to cold air cold objects, or cold liquids. And this may also lead in winter urticaria also. Heat contact urticaria, warm object in direct skin with the skin, exercise induced or aquagenic. So most of these conditions are quite rare, but symptomatic dermographism and delayed pressure urticaria, cholinergic urticaria, these are a little more common. But rest of the conditions can be quite less common. So coming to again symptomatic dermographism, it's a common physical urticaria. This is generalized pruritus and wheals on friction, scratching and stroking. Mucous membranes are unaffected. There is no angioedema. Treatment is you can just avoid the friction and have loose clothing. So it can be easily reproduced. And the baby who is developing rashes over the shoulders lasting for more than 24 hours, one can have more distribution of the bag, or we can have a trolley kind of bag where the weight is not much on the shoulders and it is equally distributed over many body parts. So it can also be triggered by prolonged sitting or lying or tight clothing. So commonly seen over the shoulders, waist, palms and soles. So wheals last for more than 24 hours, pain can be present, and redistribution of the pressure is the simple treatment. And coming to chronic spontaneous urticaria, it's seen more in the older children. It can be transitory, pruritic, sometimes symmetrical and maculopapular rashes, more common on the trunk, neck, and limbs. It's triggered by the exercise and emotional stress, resolves after, say, 1 to 2 years on their own. What is the pathogenesis? It can be autoimmune urticaria, IgG antibodies to the alpha subunit of the Ig receptor, or less commonly IgG antibodies to the IgE itself. Sometimes they can be autoallergy. Many of these will have antithyroid antibodies present. So they just trigger the Ig receptors and lead to the degranulation, which releases the histamine, tryptase, cytokine, and other mediators. These are more intense and protected disease course. So one can have autologous serum skin test where these serum is taken from the patient's blood. It's separated out and is injected intradermally 0.05 ml, and this will show the reaction to autologous serum. Coming to chronic symptomatic idiopathic urticaria, despite extensive workup, cause may not be found, and it can be sometimes triggered by the infections also, UTI, dental caries, or mycoplasma, hepatitis virus, and even by the giardia or entamoeba. The type 1 allergy is extremely rare. Pseudoallergic reactions to food or non-steroidal anti-inflammatory agents, psychological or emotional stress may again precipitate these kind of urticaria. And these are part of the majority of the urticaria, idiopathy. So how do we approach to a case of urticaria? First, we have to know the duration and the frequency of the symptoms. So once we are asking the patient, we have to take a detailed history. When did they experience these symptoms for the first time, for how long it has been happening, and how long these symptoms last. Once the condition is precipitated, for how long these symptoms last. And if there is any diurnal variation, or what kind of exact skin symptoms are present, whether they are mainly wheals or angioedema or both kind of conditions are present, and whether there is a pruritus is present or not. So we have to take a very detailed history. Is it reproducible, like after eating some particular food? And does it occur only after a particular food? Does it occur after contact with an allergen to which patient is sensitized? Could it be related to drugs patient has taken? Most common are the non-steroidal anti-inflammatory agents, aspirin or ACE inhibitors. Do the individual lesions last more than 24 hours? Are the arterial lesions tender or painful, or there is a burning sensation? Does the skin show evidence of the residual petechial hemorrhages or purpura or bruising? So from here we can kind of differentiate what kind of chronic urticaria is present by the time of onset of disease, number, frequency, and distribution of wheals, associated angioedema, whether it's induced by some physical or agents or exercise. If there's any family or personal history about urticaria, and occurrence in relation to daytime symptoms suggestive of infections, any previous therapy or response to the previous therapy. So duration of the symptoms can give us a clue how long the wheals last. Say in inducible urticarias, they last for about 1 hour, but the contact urticaria can last for about 2 hours. Once the offending agents is removed, the symptoms may subside. Spontaneous urticarias, they last for about 24 hours. But if there's an associated vasculitis, then it can last for more than 48 hours. So coming to various tests, how we can induce symptomatic dermographism, mild stroking of the skin with the tip of pen or tongue depressor, or we can use even dermographometer. I'll show you a little later at the pressure of 36 grams per millimeter square. And for delayed pressure urticaria, we can place a shoulder sling with weight of 7 kg for 15 minutes. And patient normally records the symptoms over next 24 hours because it's a little delayed response. Cholinergic urticaria, we make the patient exercise for 15 minutes beyond setting. Once the patient has started sweating, again, patient has to continue for the exercise for next 15 minutes. Or passive heating of one arm to 42 degrees with water bath, or whole body can be immersed in water. For cold contact urticaria, ice cubes for 5 minutes on the arm temperature threshold. We can use a temp test which is available. It's a kind of device which regulates the temperature. Heat contact urticaria, application of the test tubes containing warm water at 44 degrees, or again use the temp test. Exercise-induced urticaria, treadmill testing or exercise, bicycle can be used. And in achogenic urticaria, we apply water compresses at 35 degrees to the trunk or water. Patient can be immersed in water for 10 minutes. So this is the dermographometer pen, or we can use the stroking agent. And over here, application of ice. And this is the temp test device, which can control the temperature. Blood test, we need just basic blood tests like differential blood count, CRP and ESR. Extended diagnostic workup is required for only few patients, because most of the time for identification of underlying causes of eliciting factors or rule out any other possible differential diagnosis. And we have to rule out the infections like dental caries or urinary tract infections, any functional autoantibodies, the autologous skin serum test where the patient's blood is taken, it's separated, serum is separated and injected intradermally. And we can get the thyroid antibodies done. And the allergic skin test, as we were discussing with Dr. Nagaraju, will be more discussed in the allergic testing. And in severe systemic disease, we can get the tryptase done, and sometimes the lesional skin biopsy may be required. Specific IG urticaria panel are not recommended. Skin prick test can be advised if clear link is found with specific food items. Patients with chronic urticaria should be assessed for disease activity, impact, and control at every visit. We can have a urticaria acuity score for assessing the disease activity in patients with chronic spontaneous urticaria. Use of urticaria quality of life questionnaire is important, and urticaria control test for assessing the disease control in patients. We have to know the symptoms, how the symptoms are behaving, but there are no validated disease-specific tools for children available right now. So once we are scoring, we have to know whether the wheels are present, how many wheels are present, and for how long. So either score 0 is no wheels, 1 is mild, less than 20 wheels, lasting for less than 24 hours. Moderate is 20 to 25 wheels or lasting for more than 24 hours, or intense are more than 50 wheels. Similarly, for pruritus, either mild or none. None is 0, mild is 1, where it's not troubling the patient. But once it's causing the trouble, it can be moderate or intense, where severe pruritus, which is sufficiently troublesome to interfere the normal daily activity or sleep. And then we count the score. If the score is less than 6, it's well controlled. 7 to 15 is mild. 16 to 27 is moderate. And more than 28 is severe score. Similarly, urticaria test, how much have you suffered from physical? It's based more on the interview of the patient, like how much the patient's life is affected with the urticaria or symptoms of urticaria, like itch, hives, or swellings, and how it's affecting the quality of life, and whether the patient is responding to the treatment or not. Overall, how well have you had your urticaria under control in the last 4 weeks? And coming to the treatment part, the goal of the treatment is to treat the disease until it is gone. Most of these cases resolve spontaneously. The therapeutic approach to chronic urticaria can involve identification and elimination of the underlying cause, avoidance of the eliciting factors, tolerance induction, pharmacological treatment. The basic principle of treating is as much as needed and as little as possible. So we should start with the lower doses, and if required, we can step up the dose. So this may mean either going step up or stepping down depending upon the symptoms of the patients. The only definitive proof of a causative nature or suspected agent trigger, we can have a double-blind provocation test. We must avoid any drugs which can exacerbate the symptoms or trigger the symptoms. And if we can know by the history, if there is any physical stimuli which are causing these symptoms, then we have to take appropriate steps. And if we can find a source of infection, then treat the infection and the inflammatory process. And we need to reduce the physical and emotional stress, thus increasing threshold for urticaria, and reduction in the functional autoantibodies like plasmapheresis. These are required rarely, and sometimes we may have to manage the diet also, where we can, if we can find the food allergy agent, then we can eliminate it totally. And sometimes we can develop a tolerance to these. So it's useful in some subtypes of urticaria, like cold urticaria or cholinergic urticaria. Like a consistent daily exposure to the stimulus just at the threshold level is required. Example, in the case of cold urticaria, where daily baths are needed to achieve this kind, if we give a exposure to the challenging agent in a dose which does not cause the symptoms and gradually increase it, then patient may develop tolerance to it. The aim of the pharmacological treatment is to relieve the symptoms and use as much needed and as little as possible, and to reduce the effect of the mast cell mediators. The mainstay of the treatment are the second generation H1 antihistamines. Our first line of therapy. H1 antihistamines are inverse agonists with the preferential affinity for the inactive state of the histamine receptor. In physical urticaria, intake of an antihistamine 2 hours prior to the activity may be sufficient to abort the urticaria episode. First generation antihistamines, they have anticholinergic side effects and sedative action as they cross the blood-brain barrier. They penetrate the blood-brain barrier, and they can also interfere with the rapid eye movement, sleep, and impact on learning and performances. And it can cause impairment in particularly multitasking, especially driving, etc. And they can have interaction with the alcohol and drugs. So one should not use the first generation antihistamines like diphenhydramine or chlorpheniramine because of the CNS side effects, especially in children. And the second generation antihistamines like fexofenadine, cetirizine, desloratadine, levocetirizine, loratadine, ebastine, rupatadine, and belastine are available. They can be taken regularly for the treatment of patients with chronic urticaria. And by using different H1 antihistamines at the same time is not recommended. And it can be stepped up 2 times if the control is not achieved. Rather than adding more medicine, we can just step up the dose. Sometimes steroids may also be needed, but the dose is little less, 0.3 to 0.5 milligram for a shorter duration, 3 to 10 days. In cases of acute exacerbation, if the treatment with antihistamines is not controlling the symptoms and symptoms are troublesome. But they should not be used for long term and should not be repeated often. And there is no role of topical steroids, except only in certain specific conditions while using insoles, etc. Normally, the topical steroids should not be used because applying these steroids on the wheels will be of no benefit. Montelukast long-term has a limited role in aspirin-induced urticaria and food additive intolerance, but there are no studies which are available for the pediatric age group, and there's no role of fixed preparations like Montelukast plus antihistamine, and there's no role of H2 antagonists also. Sometimes the ultraviolet therapy may be required for the treatment of chronic spontaneous urticaria and symptomatic dermographism. Ultraviolet A and ultraviolet treatment for 1 to 3 months can be added to the antihistamine treatment. Now, coming to case study, a 14-year-old male was referred with articular rashes on and off since last 3 months. He has taken hydroxygen intermittently with brief relief, but was advised Montelukast for 6 weeks but didn't respond. And patient also received oral corticosteroids at 2 milligram per kg per day. So what is the diagnosis? Diagnosis is simple chronic spontaneous urticaria, but what is wrong with this patient's management? One, medicines were changed at every visit. Initially, the child received hydroxygen, and then the Montelukast was added, and even the steroids were given at a very high dose. Normally, the dose should be 0.3 to 0.5 milligrams per kg per day, and for a shorter duration, 3 to 10 days. So once child is coming back with the symptoms, say after 2 weeks, so one can almost double the dose of the H2 antagonist, second generation H1 antagonist. And again, the dose can be increased further from 3 to 4 times if there is no response. But most of the children will respond to this stepping up of the dose. So once, unfortunately, he didn't respond to the second generation antihistamines, then allergist opinion should be taken. And sometimes even the monoclonal antibodies may be required, like omalizumab at 150 milligram to 300 milligrams subcutaneously monthly for 3 to 6 months. So again, if there is no adequate control after 2 to 4 weeks, increase the dose. And if the anti-allergics are not working, then we may need to add the omalizumab. So what is the prognosis? It's a self-limited disorder in nearly all patients. 50% of the patients are better within 6 months, another 20% by 3 years, and further 20 years by 5 years. And only 8% can persist for more than 10 years. The severity of the urticaria may fluctuate, and it can go into remission at any time. So it is recommended to reevaluate the necessity for continued or alternative drug treatment every 3 to 6 months. The urticaria severely affects the quality of life, so treat aggressively. Thorough history taking is the most important part. So only then you will know if there is any offending agent or what is triggering the urticaria. In 60 to 70% of chronic urticarias, cause may not be found, and the investigations will depend on the history. Extensive IgG panel allergy tests are not recommended in chronic urticaria, as IgE-mediated food allergies are not often the cause. Thank you very much.
Thank you, Dr. Ajay. Wonderful presentation.
Thank you, sir.
Very nice presentation, Ajay. Very well highlighted the features and the points wherever they had to be highlighted.
Thank you.
So, he had done a very good job about chronic urticaria, as what is the pathophysiology behind it, for better understanding, and what are the different situations and where we come across these urticarias, the investigations, and the management part. And very nicely highlighted the fact, the differences which we heard for the benefit of the attendees who had heard yesterday also, the differences of management between the allergic rhinitis and the chronic urticaria. Very well brought out that how in chronic urticaria one can step up the antihistaminic, and obviously a big no-no to the first generation antihistaminic, and the role of steroids, and the dosages, and when and we have to proceed further with the further medication and the prognosis and the outcome related to this. So the steroids have got a little limited role in chronic urticaria, that is important. And however, Dr. A.K. Sharma has made this comment that for children, it is fine even if we are using the first generation of antihistaminics, because it makes them a little sleepy and decreases their itchiness. He's talking from his practical experience. And since children do not have this issue of driving and alcohol, so one can offer them the first generation antihistaminics.
Yes.
So
I
any
think sometimes it can be given in the evenings.
experts, Ajay and then Dr. Sareen?
It can be given in the evenings for children, so that it coincides with the natural sleep cycle also.
That's yes, that is the thing. Yes.
Dr. Ajay, one thing I want to know, this classification on the various phenotypes of urticaria you said, do this thing we need to clinically distinguish clinically on chronic urticaria? Is it possible for us? By history wise, we try always to the best. Do you
Only
think
history wise.
And can you make something? It makes a difference in the management. I think the treatment remains the same. Is it essential to classify the phenotype?
And it's only on the history if there's any triggering agent, because unless you remove the triggering agent, it will keep on happening. See, if you have come to know child gets urticarial rashes after going for swimming or after taking a hot bath or using, say, wool, even sometimes they develop after because in winters, this is very common, they use woolens underneath the main clothing, which irritates the skin. So the contact dermatitis will be always present unless you remove the offending agent. No amount of medicine will help.
Right. So we want to say the trigger and the irritant that should be removed first, and then you come for the treatment, right?
And you start the treatment, but unless you remove the trigger,
triggers. Right.
It will keep on happening again and again.
And I think whatever the recommendations is now, this first generation is almost out. I think I don't
Yes.
think it is recommended anywhere. You can use first generation. It is absolutely not required. But I feel the most of the literature says. If I think everyone agrees to it, Dr.
Yeah,
Sareen.
yeah. Very rightly said, Dr. Lalit.
Right.
Nowadays, Belastin is also very helpful, na?
Yes.
No sedation with
Yes.
Belastin.
Yes. Right.
It's the least sedating, and I've used it personally. I have personal experience. I could drive also after taking Belastin. Even with the other fexofenadine, there was some sort of a sedation is there, but this Belastin is fairly non-sedating.
But I believe Finargan is still in use.
Yeah, for children, it doesn't matter if you have to give it at bedtime or evening time, and it coincides with their sleep cycle, they sleep better.
Yes.
But for grown-up children,
But we have a practical experience that these first generation medicines, they control the symptoms much better as compared to second generation medicines.
I echo what Dr. Ajay has said. And that is the experience that definitely they work better, and for this.
They are better effective for rhinorrhea. Actually, rhinorrhea बहुत जल्दी ठीक हो जाता है.
No, they are effective even for urticaria and all these.
Itching is controlled much better. Itching is controlled much better with the first generation antihistamines.
उसमें थोड़ा sedation भी है ना.
See, as long as the kid is with you in the hospital and all, no, these things really work once they are admitted with you. So that
and Ajay, any indications for steroid in chronic cases? Any absolute indication where we should use it?
No, only if the symptoms are not getting controlled. If the patient is still having antihistamines.
Okay.
Only short duration course, 0.3 to 0.5 milligram per kg for 3 to 10 days.
Right.
And should not be repeated very often.
Right. Any other questions in the chat box? Then otherwise we can proceed.
Maximum duration कब तक रहता है जैसे chronic urticaria? Maximum duration, how long? Usually self-limiting है ना? Usually
3 to 5 years.
3 to 5 years.
Dr. Sharma has given a very valid comment that side effect, that sedation of the first generation antihistaminics may be useful to reduce intense itching and inducing sleep. Children are not supposed to be driving or take alcohol, so it's fairly safe.
We've already discussed that. That is why we had brought out this issue of the first generation antihistaminic. And very right.
I think Dr. Khushi is already there, and she had transferred the data to me also about Dr. Nagaraju's remaining talk. And if she's there and she can transmit, then we will start that once the Ajay's talk is over and comments are over.
Yes.
Any further comments?
I think we can go ahead for the next.
Yeah, we can surely.
मैडम मैं एक चीज कहना चाहूंगा डॉक्टर अजय के लिए कि आज भी बहुत वंडरफुल प्रेजेंटेशन, और मैडम कोविड में भी इन्होंने बहुत बढ़िया दिए थे प्रेजेंटेशंस डॉक्टर अजय के. I remember.
Sir, he has been appreciated by Central IAP for this activity. He has done 100 plus modules of COVID-19 all over India. So a round of applause for him from my side also. He is a member of our IAP Delhi team also. So I am always proud of him, and will always remain with us.
So are we all. We are all proud of him.
Yes. Sir, अभी तो मैं क्या ही सकता हूँ ना.
बिल्कुल.
Thank you, sir. Thank you. I think we can proceed with the next thing.
Khushi, are you there on the screen? You're
Doctor,
there?
I'm here. I've just joined through my phone, sir. That's the thing. I'm not able to connect from my laptop.
Should I start then?
Sure, sir. Sure. Should I guide you? How should you start?
I've opened the presentation, and now you said I should maximize it.
Yeah, just no, we are not able to see the screen yet. So just minimize that tab in which the presentation is open. Just minimize it.
I've minimized it, yes.
Yeah, come back to Zoom.
I'm on the Zoom.
Yeah. So now when you click on share screen, you will be able to see that tab.
Yeah, I'm able to see it.
Just click on that, and so you have to include sharing sound.
It's okay now. Now start from the slideshow.
Is it visible?
Yeah, it
sir.
is visible. It is visible. And I
Visible
wanted
exactly
to,
at the place. Exactly at the
yeah,
same place.
yeah,
Sir, please
exactly.
start.
I just wanted to apologize for the fact that I had spelled out Dr. Nagaraju's institution different.
It's
He
not audible,
belongs
sir.
to Savita's medical center, medical college, rather than Ramachandran. That was my mistake. So I wanted to apologize for that.
Now I'm starting it, but sound कहाँ पे है खुशी?
साउंड के लिए आपको शेयर साउंड करना पड़ेगा. एक बार आप रुकिए, मैं आपका स्टॉप शेयर करती हूँ. कम बैक टू द जूम स्क्रीन.
I'm stop sharing, coming back to the Zoom screen. Yes.
यस. अब सर जब आप वो टैब पे क्लिक करते हैं ना, तो नीचे एक ऑप्शन होगा शेयर साउंड करके. आप
शेयर
देख पा रहे हैं
स्क्रीन
उसको?
नहीं, शेयर स्क्रीन पे क्लिक, उसके पास तो कोई ऑप्शन नहीं है शेयर साउंड का.
नीचे वाले बार पे जहाँ पे ब्लू वाला शेयर लिखा रहता है ना, उसके लेफ्ट साइड में शेयर साउंड का ऑप्शन है.
नहीं, शेयर स्क्रीन है, रेज हैंड, शेयर स्क्रीन, चैट, क्वेश्चन आंसर, पार्टिसिपेंट्स.
वहां नहीं सर, आप एक बार शेयर स्क्रीन पे क्लिक करिए. शेयर स्क्रीन पे क्लिक कर दीजिए.
क्लिक इट. यस.
हाँ, अब जहाँ पे अब नीचे वाले बार में देखिए शेयर साउंड का
उसमें
ऑप्शन
शेयर
दिख रहा है.
साउंड है, शेयर साउंड है, ठीक है.
हाँ, वो शेयर साउंड पे क्लिक करिए
हाँ
और
जी,
वो टैब को शेयर करिए.
ठीक है. Is it visible now?
यस सर,
Yes,
इट्स
sir.
विजिबल.
So I'll just play it and see sound आ गया.
Forearm skin less sensitive than
Yes, sir. Sound
Yes,
is
sir,
there.
आ गया.
we use forearm only because convenience purpose. How you do? These are the allergens, what you selected, what you want to do it because of by history wise. And the lancet is a very important lancet. This is the allergy lancet. You cannot use the blood lancet where the tip is very, very small. And mark on the skin, the forearm, where you can see the marks. You can see at the distance of 2 centimeters. And place the drop, small drop in the angle you can put it so that you need not to waste the antigen. And then use this lancet, prick it with sideways what I mentioned you. That is the modified prick test, we can call it as. This is the prick test normally. That is a modified with sideways to do, is easy to do and measure it. And once you do it, waste whatever the leftover one you can able to remove by using the either blotting paper or you can able to take individually also by this thing and wait for 15 to 20 minutes until the results will see. Once the results has come, you have to see one is called as for negative control, it has to be less than 3 millimeter, where the positive control more than 3 millimeter. What is positive control histamine? I think we have to do it first. And negative control saline, we have to do first. Because if it is positive means more than 3 millimeter, we cannot proceed. At the same time, positive control is less than 3 millimeter, we cannot proceed for further testing because patient is taking antihistamines. Then only you can go. If more than 3 millimeter, you consider as a positive for that antigen. See this already I told you. This is called as allergy lancet, 1 millimeter tip. This is called as blood lancet. Induces the blood only. That's why we cannot able to do this procedure. It is once blood is there, positive results will come. How many allergens to be tested? This needs a lot of experience, clinical experience and knowledge is very, very important. For that, you have to take a good history, age of the patient and environment and living conditions. Where I give you an example. A child is less than 5 years, you need not to do for the outdoor allergens. More of a food you will do it. History shows that is more of a dust mite type of thing. Early morning symptoms and night symptoms when you lie down in the bed, then dust mite, you can select it. Environment where he's staying, if is pollens in that environment, you have to know that because birch pollen is not common in South India. That's why you need not to do it. Only Himalayan areas only positive. So you have to know about aerobiological data of your area. You have to know large number of tests we don't allow. We don't want to justify it by doing it. Simply they don't do. I just tell you a person is a vegetarian. Why you want to do a non-vegetarian diet testing? It's not good at all. And history is going to guide you. Patient say that I take this food is developing symptoms. Then only you can do. Otherwise, all food are not definitely not good. you have to think about what is allergenicity of pollens. Some pollens are mild pollens, some people are moderate allergenicity, some has severe allergy. According to that, you can able to select in that area. Cross reactivity, you know, some pollens are cross reacts with food cross reacts with the pollens, and dust mite cross reacts among yourselves, and also to the prawns and crustaceans, other crustaceans, and also to the cockroach also. So we have to know about the cross reactivity when you are doing testing, and you have to know about whatever I told you, aerobiological data. Infants, preschool children, and school children. That way you can think over infants, what you have to do, you can think about with that history. Preschool children, what you have to take it, and school going children in the school environment also you have to find out how you are spending and all, what is the school environment, how much time you are spending, where symptoms exaggerate in school going, that you have to find. In adolescents also you have to find. For that, we need good knowledge. Clinical acumen is necessary, and clinical experience also very, very vital. How do you interpret? We did already 3 millimeter wheel is the positive. Yes, you see that millimeter is positive. This is the projections is called as pseudopodia. Once pseudopodia we see, that means it is a very severe allergy. That you have to understand. Here also pseudopodia is there. See, yeah, that is one thing. Positive indicates sensitization, not necessarily a disease. So please understand, anybody who is positive means don't jump into conclusion that you have got allergy. Don't tell that. You have to correlate with the clinical history. Then only you can take. So once you do the skin prick test and revisit the history, that word you can call it. Take the history first and do the skin prick test and revisit the history. That is the one thing you can do. When you ask patient to that, this is the thing, dust mites is the thing. You can ask him, when your symptoms more common, in the early morning symptoms, when you lie down in the bed, night is more common. Early morning when you will get sneezing and nasal block will be there. Then it is more of a dust mite. That we can also ask, always interpret with the evidence of the history only. Without history, you cannot. Like somebody we have got apple positive, and patient says, I take apple, nothing will happen. That means it is not necessary. It may be a cross reactive, also false positive reaction. That's only you have to think about. Size of the wheel, you can say that this is very big size is there. So it is severe allergy. It's not going to do to you at all. We are doing a wonderful study. I think we are going to come out with a big study about that size of the wheel and the severity of the disease. We are going to tell you. Negative test, maybe sometimes we found everything is negative, but still patient has symptoms are there, maybe due to non-inclusion of the protein, or maybe patients, whatever may be expired allergens, we used it, or patient allergens not stored properly. All these things will be, think about that. When you say that, some people will get less reactogenic. Why some people are less reactogenic? That means wheel size. Damaged skin due to skin exposure. Your skin is exposed to that damage. Skin cancer people. And chronic renal failure, any of the chronic diseases, immunosuppressive patients, aged above 65, of course, this is a pediatric, but anyhow, we are doing 65 years above. There's infants, very small infants, small wheel will be there. And also, after immunotherapy, there will be, wheel size will be decreased. That's why we have to know all these things before going for a skin prick test. A lot of people have got a lot of apprehension about the skin prick test. Anaphylaxis will occur, death can occur, that's the only thing. We are doing so many tests, so many lakhs of tests we did, and we didn't find anything very abnormal. But what happens, it is, some syncopal attacks can occur, vasovagal attacks can occur. Vasovagal attacks means you do just prick it, immediately child may feel excessive sweating and fall down. That is the only thing. I'm going to tell you how to differentiate between vasovagal and anaphylaxis. It is a highly safe procedure, extremely safe procedure. And sometimes patients come back with that, saying that after 30 minutes waited and gone back and say that, sir, after 1 hour, he said that I highly painful and tender, these reactions are very high. It is non-significant, nothing to worry at all. And some people will say that late reactions. Now you did that time, it is not increasing, now it is increasing, that is not going to significant at all. Systemic reactions are very, very, very rare. Please understand. When occurs, if you're doing for fresh fruits and also for the atopic dermatitis in patients and latex allergies, unstable asthma patients, and those infants less than 6 months, there is a chances of there is reactions can occur. But We are not seeing much of these cases. If you go on select properly patients, you won't develop it. Whenever there are these type of patients, observe another 20 minutes extra. That already you are observing 30 minutes and then 20 minutes extra, you have to observe it. And sometimes theoretical possibility of infection may be there, headache will be there. These are all very minor, need not to worry at all. How do you differentiate between? I told you already, this is very important. When you prick itself, patients will fall. Most of the time, mainly because of sitting position, standing position will do, lying position may not come up. This type of vasovagal. How do you differentiate? Pulse is more of anaphylaxis tachycardia, whereas vasovagal attack it is most of a bradycardia. Blood pressure may or may not be normal. Also, vasovagal may be anaphylaxis, hypotension will be present. Cough, wheezing usually absent. Anaphylaxis usually present. Pale, extremely pale vasovagal attack. We see extreme sweating and fell down patient from there. In normal and only late stages only cyanosis occurs in anaphylaxis. Urticaria, angioedema normally absent. No involvement of skin involvement. Whereas anaphylaxis, most of the time, skin involvement will be there. This happens as you prick itself, it will happen vasovagal attack. Immediately, seconds it will happen. Whereas it takes minutes to hours for anaphylaxis to develop. Patient will tell after waiting, after you did everything over, then only most of the people tell, or in between that thing, they may be tell. Whereas vasovagal first prick itself, they were able to tell. And vasovagal, there will be nausea, vomiting. You can ask the patient. When you, what I do in my practice, I hold the hand of the patient. When I am doing with right hand, left hand, I hold the patient's hand. See that patient extreme sweating is there, then I'll ask, are you feeling giddy? Then he says, by the time, they immediately she fell down, vomiting, this thing will come. That is indicative vasovagal response. You ask them to lie down, very good response will develop, extremely good response. Whereas anaphylaxis, no change at all. And anaphylaxis, most of the people complain of abdominal cramps and vomiting. But here, there is no cramps in vasovagal attacks. Do not do the test in standing position, or even some patients, even sitting position also can cause. But inquire about allergies to that, what you are doing allergen is important for anaphylaxis. How do you store antigens? It's very important. Stability is of the antigen and potency is more dependent on how do you store it, very important. Allergen extract potency deteriorates over the time. And higher temperatures, we expose more and more higher temperatures. You have to store at 2 to 4 degrees centigrade in the refrigerator, and extract usually preserved with 50% glycerin because stability will be maintained. So you don't use whatever expired extracts. What are the common errors you do? That mistakes do normally people you do less than 2 centimeters, because what happened here, the distance they cover it, so they want to use for so many antigens they want to test, and then 2 centimeters below that thing they can able to do it. So that overlap reactions occur that you cannot able to see whether reaction due to that previous one and this one we don't able to understand. Induction of bleeding. If you bleeding leads to false positive reaction, and when allergen enter into systemic circulation can cause systemic reactions also. Please understand that. Insufficient penetration. Some of the people, what they do is that they think that they are penetrating, they are gone, but they never able to puncture it at all. You ask the patient, can you feel it? Patients, most of the children, they say that no pain at all, because most of the parents will say that pain will be there. That when they feel that that afraidness, when you prick it, such a less pain. No pain. People may feel that mosquito bite lesser than mosquito bite. That's the only thing. Those who won't prick it at all, they say that not happened at all. They'll say that, then false negative results. A lot of ambitious practitioners, especially initial time, they never prick at all. That's the only reason why these most commonly occur with plastic devices, where we cannot able to know that pricking sensation we are not able to find out. Spreading allergic solutions. You know that atopic dermatitis patients, once you put that thing, automatically spreads. No, immediately won't be there. And if you put big drop, it spreads to other places. 2 centimeters cross that and go to that thing, and wrong results will get. That's the only thing, not to do this type of things. What are the pitfalls normally we do? A lot of people think it's easy to do skin prick. What is there, we will do it. But you need training, expertise, and skill to get a good, accurate picture. And Whenever you do the inexperienced personnel, a lot of changes. That's why we do normally ask them to do histamine proficiency test. We ask the patient to do, or who are going to training, going to undergo training in how to do the skin prick testing. Ask them to do the histamine. For 10 places, we will put histamine, ask them to prick it. All the wheels must be equal, or less than 20% difference has to be. Then we will allow him to do the test. That is only we practice. I think you have to practice like that before going for the thing. Failure to store the extract properly. A lot of people, they carry the things to some other hospitals. They carry that, may lose the potency. And non-relevant allergen, not required at all. That allergens we are unnecessary doing. That causes a lot of negative reaction. Clinical situation is not doing it. So I already told you, don't do the tests we are doing unnecessarily. That will be causing a lot of apprehension to the patients at all. And fail to test up clinical relevance of positive or negative tests. That's a very important. Patient is full of allergy. We can see that thing. And when you do the test, nothing will happen. Maybe you might have taken antihistaminics or whatever happened. You have to inquire into that and find this. Sometimes you may not establish at all. Sometimes it may be positive. It is maybe and may not be explained in the history also. Some 2 or 3 times may be required to sit with the patient to discuss about that. We talked about in vitro testing and vivo testing. How do you compare it both? That is the thing. Skin prick test is a gold standard. Very simple, sensitive specificity, very good. Strong clinical correlation will be there. False positives are very less. Immediate result. Patient can see immediately in front of their eyes and the belief of the disease about the results very easily compared to the immunocap one. Very cheap, less expensive compared to the in vitro testing. Drugs and venoms can be whatever you want to test, you can able to do. Intradermal test, in skin prick test, you can do. It is more of an allergist point of view, allergist domain, we can call. No calibration is required. Where immunocap, you need a qualification. Whereas here, immunocap is more expensive, and only advantage is that it's a very small amount of blood is reading. You can do great for screening purpose, you can able to do. Even if you're not able to stop antihistamine like urticaria, where you cannot able to stop it, there you can able to do this test. Food allergies, where food allergy overgrown or not, we can able to make out. Safe in children, those who are afraid of needles, or those who have got anaphylaxis, who are afraid to do the test, some people. And we need a very expensive equipment, and for the place and all required. That's why its cost will go up. It is more of a general practice, the way anyone can do it, and it must be done for allergic bronchopulmonary aspergillosis. We can do for very young children also, because where skin prick test, most of the people, allergists only do, other people cannot do. Then you can able to do the in vitro test. Then let me talk about intradermal test. This also done in volar aspect. What you see in the picture also same thing. We use 26 cm gauge needle, bevel down only we have to use, just like what you do in the Monto test we used to do. That same way you can able to inject 0.01, 0.02. You have to produce 3 millimeter BEP. That is very important. No air in the syringe. And you must see that the amount be injected must be correct. 0.01 or 0.2. If you injected more, you'll get false positive. Inject less, negative results will get. That is the one thing. Where we do in the allergic rhinitis, asthma, respiratory allergies, or food allergies, where you do normally skin prick test next to, but history suggesting, then we can do intradermal test. Then most probably we can able to do it. More sensitive than skin prick test, because the concentration is very, very high. I told you already. And false positive reactions are very high. If you do with the food, we can get anaphylaxis also. Be careful with the intradermal test. Normally, we practice intradermal test for the venom allergies and drug allergies where skin prick test negative. There is another test is called prick to prick test. A lot of parents will come to us, ask the patient. My child is definitely allergic to banana, allergic to apple, allergic to so many vegetables. There's so many things they go on. So that to prove to the mother that even history says, but we are did skin prick negative, then you prick that whatever the liquid one and then press it, so that we can see that patient that this is called prick to prick test. We can able to do. and also you can able to overall allergy syndrome also you can able to do this. This is the thing what I told you how to do it. See, bleb, 3 millimeter bleb, you can see here. That's one thing what you can able to plan for the drugs and venoms. My dear friend, I already told you, all of you, that positive means only sensitization to oil. Does not mean it's not a allergy disease. Negative test does not mean allergy, already told. You must be interpreted with the clinical history only. Clinical history and SPT will guide you. So we have to know that whether it is genuine allergy or cross-reactivity or false positivity by only correlating with the clinical history. For that, knowledge, experience of clinician is very, very important. Summary, I already told you everything, how to do it and how to interpret it, the highly safe procedure skin prick test, how to compare between skin prick test with the in vitro test. The burden of allergies is immense globally as well as in India. Please understand that daily and yearly we are seeing increase of allergies. More and more awareness is coming out and more of allergy diseases are coming. We need better management of allergy disease to give quality of life to our patients. And we have to diagnose appropriately. Nowadays, patients ask us, what allergy I got? I want to know. Like that, parents are asking nowadays. So for that, skin prick test or blood test will be very, very useful. Skin prick test is a manual technique that requires training, skill, and expertise. Please understand that thing. You have to learn your own technique. Don't say that it's very easy to practice. Very difficult. Sometimes wrong results may occur. Allergy testing, its clinical interpretation is both art and science. It requires your experience and your technique is more important. Probably the most reliable and clinically valuable and cost-effective test is allergy skin prick test. Standardized allergen extract is necessary. Don't use non-standardized to get a good results. Thank you for this opportunity given to me by DAAP. Thank you very much for all of you who has listened this talk.
Indeed, we are very thankful to Dr. Professor Nagaraju for his excellent talk, which has been recorded, and very nicely he has brought out all the points and aspects related to skin prick testing, and he made it look so simple and so practical, and he made it actually alive. That's the word I wanted to use. And I could imagine, having attended his workshop, that these were the things, which he was talking about in that workshop when he conducted related to allergy testing. And so there was a lot to learn, and there are a lot of skill building also. How to do the skin prick testing is part of it. And I'm sure that many of us would start working on it and get the practice, and it will become very useful for everyone, especially the ones who are interested in these allergic disorders, and take it further and use it in their clinical practice also. And but I know definitely that these allergens which are available are a little expensive, but however, there are certain situations where it becomes necessary, and we can go ahead with it. And any other comments related to that?
A wonderful talk, and so much of dedication. I think we all dedicate this whole program to our dear friend Dr. Nagaraju, and he's been close to almost all the senior IAP members. And I think while he was contesting, we used to have talk almost every week. And but I think sad thing that, but he has done a lot for our academy, and we will remember him through all his good work, and cherish the sweet memories which we had with him. Any other comments from Dr. Ajay, Dr. Lalit, Dr. Sareen?
बस यही कहना चाहूंगा कि he was a great man, और बहुत सबको साथ लेके चलते थे डॉक्टर नागराजू सर। जब हमने सर जो इसका मॉड्यूल का नाम ले लिया, सबसे उन्होंने राय ली थी, एवरीवन, सबकी ओपिनियन लेके सबको फिर बता के कि अपन ये रख लें, दिस विल बी गुड। एंड ही वाज वेरी पर्टिकुलर, हर एक चीज में मास्टरी थी उनकी बहुत ज्यादा, एवरी एस्पेक्ट ऑफ द एलर्जी। एंड ही वाज आल्सो वेरी पेशेंट फ्रेंडली। पेशेंट्स के लिए हमेशा वो कि चाइल्ड का डेवलपमेंट नहीं रुकना चाहिए, रिस्ट्रिक्ट मत करो, एंड मिनिमम इन्वेस्टिगेशंस कराओ उसमें ना, एंड हिस्ट्री डिटेल में लो, इसी पे एम्फसाइज करते थे वो। वी कैन नेवर फॉरगेट हिम, नेवर। ही इज ऑलवेज इन आवर हार्ट्स।
Right, absolutely right, and it is such a big loss for whole academy and whole pediatricians for us. This was a specialized branch. He was really master of this thing, allergic chapter. We had got so much learned from him for over the years. Really, we are missing him today. And the best thing is that he had made Dr. Sangeeta said things were made very simple. Whatever the module he's made is very simple. कोई इतनी complicity नहीं है. This thing is to be done. This thing is not to be done. Very simple. And I think for the postgraduates and those things, IAP has also started an allergic chapter. I think this is a 1-year program, I think. And Gangaram is also having 1-year program on allergy. I think these are the specialist field. Basically, I think for all those who are really interested for this, it's a specialized field. I believe that it is not for anybody can do it. It will have to expertise in this skin prick testing and the various kinds of allergens available. And depending on the area which we are using, depending upon the clinical history of a patient, I think there's so many parameters involved in allergic tests. It is not just that we can just start doing, and the facilities available in your center where you are doing this test. Any comments, Ajay?
No. Thank you, Dr. Lalit. I think we should subject the children to as less pricks as possible, because already even the vaccine companies are making 6-in-1 so that they are subjected to less pricks.
No, this is a specialized field.
And we have to emphasize more on the history taking, because most of the time history taking will be the most ideal investigation.
Any questions in the chat or anything?
Not related to that, there's some
long comment
by Dr. Sharma related to Dr. Ajay's talk.
Oh, he said that as chronic urticaria is more of a self-limiting condition over the years, so why subject the child to cruelty of the skin prick test?
That is not meant for urticaria, I think.
Yes.
No, not meant for urticaria. I don't think the skin test is needed. Ajay, it is required? I don't think so.
No, it's not required.
Right. I think any other thing, then any other thing.
Right.
Thank you so much.
Yeah, I think we had a wonderful session. It was though
सर आज तो ऐसा लग रहा है जैसे फिजिकल मीटिंग हो रही हो ना, इतनी इंटीमेसी पास हमें ऐसा लग रहा था मैडम. इट इज लाइक ए फिजिकल मीटिंग. थैंक यू सो मच. एक्टिव इन्वॉल्वमेंट सबका मैडम. थैंक यू सो मच.
सर तो आप भी हैं, you are also a part of the team. That's why it's so much of harmony is there. सर आप बड़ी इंटीमेसी रहती है. You are always it's always you are together. It looks you are close to us.
He gives a very personal touch to everything, to each one of us. That
Actually,
is the thing.
Dr. Singh तो सबको जान गए हैं. Being the coordinator of so many programs, I think सर आप नॉर्थ दिल्ली पूरी दिल्ली को तो सारे को जानते हैं. क्यों सर?
लास्ट ईवी मीटिंग में हमने सर को और मैडम दोनों को मिस किया.
मेरी एक्चुअली क्या है, मेरे लुम्बोसेक्युलर डिस्क प्रोलैप्स था, तो इसलिए now I am better. इसलिए मैं आते हुए भी नहीं आ पाया.
Take care.
I am better now.
That's good.
Thank you.
Good night.
Good night.
Leave.
Okay. Thank you.
Thank you, delegates, for being with us. Thank you very much.
And we thank the participants who were there right till the
thank
end.
you, Khushi,
I'm sure they enjoyed. Thank you, Khushi.
Okay, thank you. Thank you, everyone.
Thank you.
Good night, Dr. Sareen. Good night. Jai Hind. Jai Hind. Jai Hind.
Good night, sir. Good night.
Okay, thank you.
Bye.
Good night, sir.
Bye.
Bye.